Okay, so we'll start with the cardio part. So if you look at the JVP, you should know the A wave occurs because of atrial contraction. Okay, C wave is tricuspid bulge that occurs. V wave is venous inflow of blood. Okay, venous collection of blood results in V wave. In all these, the only question they've been asking is that C wave occurs in what part of cardiac cycle? It occurs during isovolumetric contraction. Okay, isovolumetric contraction phase of ventricle, you get C wave. That was the question they were asked in the INICT. X descent is atrial relaxation, X dash, X prime rather is ventricular systole, and Y descent is early diastolic filling. So A is atrial contraction, V is venous filling, C is tricuspid bulge. Initial X descent is atrial relaxation. This major part of X descent that you're seeing is called X prime and it occurs in ventricular systole. So ventricular systole kind of starts from here and goes all the way from here. Okay, this is the duration of the ventricular systole. This is the ventricular systole. Causes of giant A waves are any blockage downstream of right atrium will cause the A to become tall. So tricuspid stenosis, pulmonary hypertension. When atria contracts, ventricle should stretch and relax. If it unable to collect the blood, then also you get giant A wave. In all these, recently in NEET they asked a question. Patient has got a mid-diastolic murmur plus has got giant A waves. What's the diagnosis? And they asked, is it MS or is it TS? Remember, this is a left-sided problem and it should not affect the JVP. Although it must come with a mid-diastolic murmur, but it will not come with giant A wave. So the correct answer is tricuspid stenosis. Okay, tricuspid stenosis. So remember in our exams, always when you have a better choice, always go for that. Many students marked mitral stenosis in the exam and came and they argued, sir, with mitral stenosis, long-term pulmonary hypertension will occur. With pulmonary hypertension also giant wave will occur. So like that, if you keep stretching it beyond the examiner's imagination, you can prove anything to be correct. But the correct answer here, the best answer is tricuspid stenosis because it explains giant A waves without any complication, and mid-diastolic murmur can occur in tricuspid stenosis also. So that is the better answer. So look at the Kennedy waves. AV dissociation should be there for Kennedy wave to occur. When atria contracts, ventricle also should contract simultaneously. This can happen in complete heart block, VT or ventricular ectopics. What is CV wave? When ventricle contracts, then remember in ventricular systole, the pressure in the atria should come down because ventricular systole pulls the floor of the atria down. If this drop in pressure is not there, rather the C wave merges with the V wave, it indicates that during ventricular systole, atrial pressure is rising. So in ventricular systole, if atrial pressure is rising, the blood from ventricle must be regurgitating in the atria. This is nothing but tricuspid regurgitation. Okay, this is referred to as CV waves. Okay, so CV waves is nothing but tricuspid regurgitation. Giant V wave basically is venous collection of blood in the atria. Normally the blood from the atrium should come from SVC and IVC. If you get additional blood from anomalous pulmonary veins or from tricuspid or from ASD, so this comes from left atrium, this comes from the ventricle, this comes from additional blood from the lung. Any other additional source of blood in the atrium will make the V to become very tall. Okay, it's a very logical, simple approach. It came from left atrium, ASD. It came from ventricle, extra blood came from ventricle. Apart from SVC, IVC, more blood came from ventricle, tricuspid regurgitation. It came from anomalous pulmonary veins. In all these, the V will start becoming tall. V is venous collection of blood in the atria. Rapid X and rapid Y, remember the mnemonic PATAX. In patients with tamponade, you get rapid X, and in patients with constrictive pericarditis, you get rapid Y descent. Although you should know in constrictive pericarditis, you get a normal X descent and a rapid Y descent. Because of this, you will get a graph that will be showing this sharp Y descent but normal X descent. This looks like what is called M pattern graph. In a patient with cardiac tamponade, you will see X descent is sharp but Y descent is hardly there. So Y descent may be absent, X descent is deep. This is the kind of graph that you will see in a patient with cardiac tamponade. Okay, remember absent Y descent or minimal Y descent, sharp X descent, tamponade, X descent normal, Y descent is there, both there, looks like an M. This is what is seen in constrictive pericarditis. So you can see the picture here. This is how normally it should be, and Y generally is smaller than X. X is more deeper. But if you find that Y is absent, X is there, Y is almost absent, tamponade. If you see X descent is also there, Y descent is also there, Y is more deeper no doubt, but it kind of looks like an alphabet M. This M pattern graph if you are getting, Okay, M pattern graph, this is highly suggestive of constrictive pericarditis. So that's a subtle difference that is there between tamponade and constrictive pericarditis they can ask you. Whenever they are asking questions on hypertension, you should know that last year only European guidelines have come out. 2023 European Society of Hypertension guidelines have come out. Okay, 2023 December. When it came in November, December, it got cleared in 2024. So mainly this year only we are now talking about European Society of Cardiology guidelines. The good thing is that European Society of Cardiology guideline and the European International Society of Hypertension guideline, you take all the guidelines. One thing you are convinced, the best guidelines are the Indian guidelines. Because what the Indian guidelines have done, they have taken the best of all, and what European guidelines are telling now, Indians have taken much before itself. Okay, in 2019 itself they have done what now it seems like from India, Europeans are copying. So, Indian guidelines is based on what you need to answer in the exam. What is going on now is IGH4. Okay, we may not have the money, but we have the brains. We have got the best guidelines overall. What the guidelines we are following is, we are saying that normal blood pressure is 120/80. Okay, 135 to 140 and 85 to 90 we are calling high normal. We are calling it high normal. Anyway, high normal and all they'll not ask you, but stage 1 hypertension for is 140. It's very easy, 140, 160, 180. Stage 1, stage 2, stage 3. 90, 100, 110. Okay, remember the word is or, not and. Either of them above this number, stage 1 hypertension. Either of these two above, stage 2. And either of these two, this is stage 3. High normal is 135 to 140 and 85 to 90 is called high normal blood pressure. They don't ask that, but you should know about these. Now what the Indian guidelines recommend is that according to the Indian guidelines, all patients with stage 1 hypertension, 140/90, you should start them on drugs. Lifestyle though you should start before itself, but drugs you will start for treatment when it is 140/90. But they also telling if the patient has coronary artery disease, or the patient has heart failure, then start the drugs at 130/80. Above 130/80 itself start drug. Okay, if the patient does not have ischemic heart disease or heart failure, then 140/90 is the cutoff. Now the controversy is guideline what India has got and European got and what international society, they are all same. Even Europeans are saying 140, 160/80. Even International Society of Hypertension same. The only difference between us is that the Europeans feel we should start treatment a little later. 160 they are saying is cut off. But European Society recently is suggesting 140/90. That is last year guidelines. So they are coming back to what Indians are following. Americans are one extreme. Americans are telling we are going to follow SPRINT study finding. SPRINT is a randomized control trial. It showed that those people who have got BP 140 and those who, some people went for target 120, those who target 140. Target 120 and 140, big difference was there. To achieve a target of 120, they use more antihypertensive drug, but the benefit 25% decrease in all mortality percentage, mortality decreased by 25% in those target of 120. Earlier we used to tell if you use more antihypertensive drugs, more side effect of drug. But now SPRINT study proved, get a better target, lower BP target, patients will live more. Okay, less MI, less stroke, everything was less. So the Americans followed the SPRINT study and they said we will start treatment for 130/80 for all patients, whether heart disease there or not there. So one extreme is American, one extreme European. Indians followed the mid path, but everybody is now coming back to the Indian pathway, and that is 130/80 if heart failure, coronary artery disease. If these are not there, then for all patients 140/90 starting point. Again, the controversy is some of the platforms are following European guidelines and giving 160 as starting treatment for antihypertensive. My request to you, in India we follow Indian guidelines. Indian association guidelines are what to be followed. So Indian guidelines for hypertension you should follow. Don't follow European, don't follow American, don't follow anybody. Just remember Indian guidelines. What do the Indian guidelines say? 140/90. When you start earlier, if ischemic heart disease, heart failure is there, start 130/80. Now what are the drugs we're going to use? If the patient is below 60, AC inhibitors, ARB, preferred below 60. Above 60 years, go for calcium channel blockers and diuretics. Okay, so this is the general idea. You try one drug and let's say below 60, patient is 50-year-old, let's say 50-year-old. You started with ARB, let's say. Patient BP not controlled, then you're going to add calcium channel blocker. Still not controlled, then you're going to add a diuretic. Still not controlled, patient is 3 drug. This is now defined as resistant hypertension. Provided patient has compliance, not like he took whenever he remembered. So he was taking the drug, still not controlled, optimum doses, this is resistant hypertension. For resistant hypertension, the treatment is add spironolactone. After that comes other drugs. When your patient is on 5 drugs, still BP not controlled, that's called refractory hypertension. If you declare the patient as refractory hypertension, last option you're going to go for sympathetic denervation. This is known as renal denervation. Or sympathetic denervation is better answer, I think. Sympathetic denervation. Below 50 years, ARB. Above 50 years, calcium channel blocker. But you're going to go for combination. If you can't control by one drug, you get the other drug. Then you add the diuretic. Remember, in diuretic we use chlorthalidone, that is better than hydrochlorothiazide. 3 drugs, still BP not controlled, resistant hypertension. Okay, in this 3, diuretic is a must to declare resistant hypertension. Resistant hypertension treatment is spironolactone, finerenone. Okay, this is mineralocorticoid receptor antagonist. Patient is on 5 drugs, still BP not controlled, refractory hypertension. What you want to do refractory hypertension, sympathetic denervation has been recently approved in the treatment. So this is the management in hypertension. If a patient has BP more than 180, 120, if the patient is asymptomatic, urgency. If the patient has organ damage due to high blood pressure, okay, maybe ischemia, maybe retinal problem, blurring of vision, maybe hypertensive encephalopathy, any organ damage in the body indicates patient has hypertensive emergency. In hypertensive emergency, indications and contraindications of drugs are MCQ. Let's say patient has high blood pressure, but the patient developed chest pain, and ECG showed T-wave inversion, let's say, okay, or ST depression was occurring. Okay, T-wave changes, STT changes were occurring, let's say. Chest pain was there in this patient. Then what you want to do? Then the main drug you want to use is beta blocker. Plus nitroglycerin is a good option. So nitroglycerin plus beta blocker or nicardipine plus beta blocker. These are the options that you are going to consider. Okay, remember the table is from CMDT I'm showing, not Harrison. Harrison has the advantage of showing the most important treatment first. It will put the best treatment first on top. CMDT doesn't follow all that, it just lists it. So anyway, nitroglycerin beta blocker is considered the best treatment when you have myocardial ischemia. What you don't want to use, understand the concept, then you can answer the question easily in the exam. The concept is any rapid arterial dilator, not veno, arterial dilator. If you suddenly dilate or arterial dilatation if you do, as the BP drops, reflex tachycardia will precipitate more cardiac damage. So don't use hydralazine, diazoxide, minoxidil, nitroprusside, contraindicated in a chest pain, in a ischemic heart disease patient, in a hypertensive emergency. Don't use. Of all these, the main repeat question they are asking in the exam is nitroprusside. Okay, they've been asking nitroprusside frequently. Be careful not to be used in a patient with ischemic heart disease. If you're looking at dissection of aorta, then if the patient has dissection, beta blocker is a must. Okay, beta blocker is a must because the tear in the aorta is because of cardiac pump thrust. First we need to cut that. Then you can add nitroprusside or nicardipine, clevidipine, any of these. But beta blocker is the first. In India, most of the time what we use simply is labetalol, or we can use beta blocker plus nitroprusside. What you should not use again is rapid arterial dilatation. No hydralazine, no diazoxide, minoxidil. Only thing that is shifted is nitroprusside you can use in dissection. If patient has severe pulmonary edema, don't use beta blocker. Now acute pulmonary edema, we want the heart to pump the blood forward, not congest the lung. So acute systolic heart failure, pulmonary edema, if you give beta blocker, then it will slow the heart and the lung will get congested. So in acute patient, is the only thing they'll ask in exam, LV dysfunction, systolic dysfunction, don't use beta blocker. So apart from all these, they're asking about stroke. Remember in stroke, hemorrhagic stroke, you're going to reduce the blood pressure because higher the pressure, more blood will ooze out in the brain. So hemorrhagic stroke, you're going to reduce. Ischemic stroke, I told you, you want to give thrombolytic or take the patient for procedure, get the BP down. If not, don't touch the BP, right? That is ischemic stroke. In stroke, generally, the drugs approved are labetalol is best, but you can use nicardipine, clevidipine, but the best is supposed to be labetalol. Okay, generally this is what we use, labetalol. You can use the other drugs. This is for stroke, but what you should not use is, repeat question in this area, don't use anything starting with the word nitro, nitroprusside, nitroglycerin. They increase intracranial pressure. Now there are other drugs also that are contraindicated. All these increase intracranial pressure. You don't want to use them. You should not use them. But repeatedly they are asking about nitroprusside. So two places nitroprusside is contraindicated: ischemic heart disease patient and stroke patient. Don't use nitroprusside. It will increase intracranial pressure. It will worsen the patient. So hypertensive emergency, I think, is an MCQ zone. In ischemic heart disease, you can divide the problem into stable or acute coronary syndrome. In acute coronary syndrome and stable, the difference is here chronic narrowing occurred over years. 10 years it will take, let's say, for the lumen to become narrow. As the lumen becomes narrow, the body will adapt. And as it adapts, then at rest it is adapted. But when exertion occurs, it needs more oxygen. It cannot get because the lumen is narrow, pain will occur. So this is the concept of ischemic heart disease. In acute coronary syndrome, plaque has ruptured. And the plaque has ruptured because occlusion occurs either two ways. Either it's 100% occlusion, that's a STEMI. Or the patient is getting occlusion, but partial occlusion. Lumen is becoming narrow in a short period of time, not over 10 years like over there. Both the conditions, the patient will get chest pain at rest. The hallmark of acute coronary syndrome is pain at rest, or any MCQ telling you pain lasting for more than 20 minutes, by definition is an acute coronary syndrome for us. Because in a stable ischemic heart disease, somebody gets pain, what's the evasive action they'll do? They'll take rest. They take rest, the pain will come down. But here, it's already occurring at rest, nothing they can do. So pain, if it lasts for more than 20 minutes, you can say this is acute coronary syndrome. With acute coronary syndrome, pain more than chest pain occurring at rest for more than 20 minutes, this patient, if the ECG showing ST elevation, you're dealing with STEMI. If the ECG shows ST depression, you're dealing with either unstable angina or NSTEMI, one of the two. The difference between unstable angina and NSTEMI is troponin. Troponin negative, unstable angina; troponin positive, NSTEMI. Now here is the important thing. Earlier we used to do traditional troponin, which was detecting very high level. I mean, your troponin level should be more than 0.1 nanogram per ml, then it will detect. Now we can detect at 0.04 nanogram per ml. This is called highly sensitive troponin. Because troponin higher generation now, we can detect at smallest level. Almost nowhere we are seeing unstable angina now. Everybody becomes NSTEMI, because the moment you see highly sensitive troponin positive, the answer will become NSTEMI. So the frequency of unstable angina across the world is coming down, because hardly you will see, because smallest troponin we can detect. Now all that we are now calling MI, it's NSTEMI, non-ST-related MI. Troponin is positive. The management principle in NSTEMI is being asked in the exam repeatedly. First, let's finish off stable ischemic heart disease. In a stable ischemic heart disease, the treatment is mainly nitrates, but don't give 24-hour nitrate, tachyphylaxis will occur. Okay, intermittent nitrates allowed. Beta blocker, calcium channel blocker. Ranolazine is never first line, it's an add-on drug, last, third, fourth option. Ivabradine you'll use if despite beta blocker heart rate is still high. Despite beta blocker heart rate is still above 70, then use ivabradine. Up till now we are giving ischemic treatment. Now we want to stabilize. You are worried about a plaque rupture. Plaque may rupture, so you put the patient on aspirin. Then you reduce the risk and start the patient on statins. So all these are the treatment for stable ischemic heart disease. Despite medication, if the patient has angina, that patient is going for angiogram. And in the angio, you will decide if the patient should go for a PTCA or the patient should go for a CABG. In general, almost all patients PTCA. CABG is left main coronary artery occlusion, or the patient has triple vessel disease. This happens in diabetic patients. Okay, left main coronary artery occlusion is there or triple vessel disease there is CABG. Otherwise, everybody goes for PTCA. So this is a broad concept in the management of stable ischemic heart disease. Okay, despite medical management, angina goes for angio. Now, when it comes to a patient who's got unstable angina and NSTEMI, okay, unstable angina and NSTEMI management, this 2023 now recent guidelines are suggesting every patient should go for invasive. What is invasive? Okay, invasive means this patient is going to go to cath lab. Now, only difference is how fast should you take the patient to cath lab. If the patient is hemodynamically unstable or the patient has refractory angina, okay, refractory to the initial medical treatment, patient's pain is not coming down. These are indications for taking the patient to the cath lab within 2 hours. Within 2 hours, you are taking the patient to the cath lab and you are doing angiogram. Okay, you might have to put a stent. Otherwise, if the patient does not have these two, you can do it within first 24 to 48 hours. Most of them within 24 hours is your goal. So now unstable angina and STEMI, non-operative management is going away. Recent guidelines are favoring invasive technique for everybody. Only difference is how fast you should do it. In the concept of unstable angina and STEMI, the plaque is ruptured, the clot is forming, it's forming, not formed. Formed is STEMI, already completely blocked already. Here it is blocking, it is becoming bigger and bigger. Lumen is becoming narrower. Your main treatment is to stop it from becoming more. You don't want the clot to expand more. So your primary treatment is not nitrates, your primary treatment is not morphine, your primary treatment is stop the clot from expanding. In order to do that, unstable angina and STEMI, you're going to start the patient on antiplatelet drug, aspirin, and you're going to start the patient on unfractionated heparin. Now in the unfractionated heparin alternatives, you can use low molecular heparin or you can use bivalirudine, of which generally unfractionated heparin is the best one because low molecular heparin takes time. Bivalirudine you use is a direct thrombin inhibitor if the patient has heparin-induced thrombocytopenia history. So this is the choice of drug. This is IV because you can control it, you can start it and stop it fast. It's a preferred option. Earlier we used to use aspirin plus P2Y12 inhibitor. In the P2Y12 inhibitors we have a lot of drugs. Among the list we have ticagrelor, we have prasugrel, and we have clopidogrel. Of all these, the least beneficial is clopidogrel. It's got very less effect. Ticagrelor is the most powerful one, and prasugrel. The recent guidelines are suggesting start aspirin upstream. Upstream means the moment the patient comes, start aspirin, and that is 325 milligram aspirin immediately you will give. Unfractionated heparin immediately you start upstream. Upstream means before the procedure. Anyway, you're going to take all patients now to cath lab, right? That's the new guideline. So start them on aspirin and start them on unfractionated heparin. They're now suggesting if you are planning to take the patient early to the cath lab, then hold on this, don't give. Once you are shifting to the cath lab, in the cath lab you can start them. You can start ticagrelor, you can start prasugrel or clopidogrel, one of those you can start. Before upstream, that means before you take the procedure, they are discouraging now to give, right? If in India this typical scenario, cardiologist will tell, yaar, sham ko I'll come, evening I'm so busy and I'm not going to come now. Anyway, unstable angina, no, STEMI, no, you manage. So aspirin was started, unfractionated heparin started. If you are anticipating more than a 6-hour delay, then start the patient on one of these. Okay, in this, if you can start ticagrelor is good, clopidogrel is good, both are accepted options you can use. Prasugrel should not be started upstream. It should be only started in the cath lab. Okay, that might fine detail they may not ask for you. Anyway, point to remember is aspirin should be started immediately, heparin should be started immediately the moment the patient comes in an unstable angina and STEMI. So this is a broad concept that you should remember now. Now, what about the other treatment? What about nitrates? Nitrates are going to reduce the pain and they benefit patients with pulmonary edema. They reduce the pulmonary edema if it is occurring and they reduce the pain. But till date, no study has shown nitrate having survival advantage, mortality benefit, whether unstable angina and STEMI or STEMI. So nitrates are used, they reduce pain, they reduce the pulmonary edema, but may not actually improve mortality. So be careful. In given a choice between heparin, antiplatelet and nitrate, choose antithrombotic. Antithrombotic is including aspirin and heparin together. That's called antithrombotic treatment. Antithrombotic is superior to nitrate in the management of STEMI. This concept they are testing in our exam. They are telling you patient came with chest pain, ST depression is there. What's the next step in management? Is it antiplatelet drug or is it nitrate? The answer is antiplatelet drug. Stop the clot from forming first. Pain and all is supportive for us. First, don't allow the clot to expand. The more it expands, the more lumen become narrow, the more muscle will go. So first to save the muscle, so antithrombotic first. Remember, unless ST segment is elevated, thrombolytic therapy is contraindicated. In this condition, as I told you, ST segment depression or T-wave inversion, ST segment depression, all these are possible, but you will not get ST elevation. In unstable angina and STEMI, no ST elevation. So unless ST segment is elevated, which is 100% occlusion of coronary artery, STEMI, don't give thrombolytic therapy. So this is your management. Earlier we should tell calculate TB score more than 3, do angio. Now they're telling everybody should go for angio. That's a more decent guide. If you have a patient with STEMI, if a patient comes with STEMI, the management is immediately rest. Remember in general one important concept, they'll test in the exam. In general ischemic heart disease, don't give oxygen to everybody. Oxygen is now recommended only if saturation is below 90%. For patients, any patient coming to the hospital with chest pain, we used to earlier give them oxygen. Now they're telling free radical injury will occur. So don't give oxygen to everybody. Give oxygen only when saturation is below 90%. So in a STEMI patient, rest is important. Start immediate aspirin, 325 milligram. Then go for morphine, oxygen only if saturation is below 90%. Use nitrates. Beta blockers should be given orally and provided patient is not in heart failure. Statins can be used, and you can even consider using heparin. So this is the management in a STEMI patient. Once you have done the initial medical management, patient should be going for one of the two, thrombolytic therapy or PCI. Now the guideline of choosing thrombolytic or PCI is based on how Harrison is giving. You can see what Harrison is saying is, if patient came to a PCI capable hospital, and if you can do the PCI within 2 hours, try to do it within 90 minutes. That's your goal. But if you can do it within 2 hours, the patient is going to the cath lab and you're going to do a PCI. Primary PCI means you're going to put a stent. You're going to take out the clot. You're going to put the stent. That is primary PCI. Percutaneous coronary intervention. You got the vessel opened. The muscle now will be salvaged. It will stay alive now. If a patient came to a PCI non-capable hospital, they are saying the thrombolytic therapy is inferior. Can you transfer the patient to a PCI capable hospital, and can you do a angioplasty and do a procedure there? In order to do that, the time from your hospital until the procedure is being done should be less than 2 hours. In order to achieve the less than 2 hour target, your hospital time, patient came to non-PCI non-capable hospital time, let's say you are working in that kind of hospital, the door in door out time should be less than 30 minutes. The travel time for transfer should be less than 1 hour. So 1 hour for transfer, travel, 1 hour for in your hospital, 1.5 hour. Pre-procedure, that hospital will take 30 minutes. Total time wasted is less than 2 hours. Still you are able to do a PCI in the next hospital, transfer the patient. If the patient comes in a place where you cannot transfer the patient to another hospital, then you are going to go for thrombolytic. Now once you are going for thrombolytic therapy, remember the idea that in a thrombolytic therapy, the plaque that is ruptured, like a volcano, it will be opening its mouth. The plaque is ruptured, this raw area, that is forming a clot now. Okay, that's forming a clot. Your thrombolytic will take out the clot, but the raw surface that is there is still there, and still one more clot can attach to this because this area is still going to attract platelets. Still a clot will reform sometimes. So we have to take care of the raw surface and cover it by putting a stent. So the idea is that thrombolytic is not sufficient. That's not the end of the game. So once thrombolytic is done, patient anyway should go for angioplasty, should go for angio. Remember, guidelines written by cardiologists. They will not allow any MI patient to go home without an angio. That's the idea. Even though patient came to a PCI non-capable hospital, you already given thrombolytic therapy. Two possibilities: either patient improved, did not improve. If the patient did not improve, urgent transfer should be done for failed reperfusion. If the patient did not improve, urgently transfer to PCI capable hospital, get a PCI done. What if the patient improved? Patient improved, chest pain went away, ECG showed improvement, then what? Can we send the patient home? No. That patient also should get an angio, but earlier you should tell 3 hours, new guidelines recommend 2 hours. Between 2 to 24 hours, patient should be transferred to PCI capable hospital, angio should be done, and most likely they'll go for a stent. So I hope you understood this idea. Every patient with MI, he came to PCI capable hospital, he came to non-capable hospital, will end up on angio. If a patient came to non-capable hospital, he gets thrombolytic, then gets transferred to another hospital where angio is there, cath lab facility is there he gets an angio and stenting done. If patient improves between 2 to 24 hours, you stent the patient. If the patient does not improve, urgent transfer you will do. Okay, so or if you can transfer a patient within 2 hours, you can transfer, don't do thrombolytic, direct transfer and get a angioplasty done. So this is what the guidelines are, and they have asked once in the exam, if patient was thrombolized in a hospital and after giving thrombolytic, 10 hours later he came to your hospital, which is a cath lab facility hospital. What do you want to do? And the patient right now is pain free, ECG is becoming normal. What do you want to do? This patient, as per the guideline, because the patient is within 24 hours, he is going to get an angiogram done. Okay, coronary angio has to be done. So any role of clopidogrel in STEMI? Yeah. So clopidogrel also can be used, but again the new guidelines suggest that in a patient with STEMI, clopidogrel should be used in the cath lab, in the thing. It's not upstream. It should be used, and clopidogrel has to be given along with loading dose. loading dose you have to give, then only you have to, you get some benefit. In general, because of all the headache of clopidogrel, we are now preferring ticagrelor as an alternative to clopidogrel. In India, we use clopidogrel because of the cost factor. Ticagrelor is more expensive, but ticagrelor is, when present, is preferred over clopidogrel in most ischemic heart disease nowadays. Okay, ticagrelor has become more superior. So clopidogrel is inferior drug, not so good. Better to go for ticagrelor. Okay. So can you use, apart from aspirin, other antiplatelet drugs? Yes, we can. Okay, especially intra-cath you can use, because we don't want the stent to thrombus. The only drug that is not allowed upstream before you take the patient to cath lab is fondaparinux. That will never be the answer. You can use antiplatelet, you can use heparin, and heparin again that we use is unfractionated heparin or low molecular heparin, because we don't want the stent that you are using and the catheter to thrombus. We don't want the, whatever stent you're putting and the thing you're putting to get, clogged up. So unfractionated heparin, low molecular heparin, aspirin, and to that you can add ticagrelor. All these drugs are used in the management of STEMI also. Okay, so I hope you understood. I hope there is clarity in the treatment. What if the patient comes after 24 hours? Now, as per the guidelines, after 12 hours, if the patient, after onset of chest pain, okay, from onset of chest pain, this is not when the patient came to hospital. After onset of chest pain, if patient comes after 12 hours, the door to thrombolytic is closed. Thrombolytic therapy door is closed. You can't use thrombolytic. You can't use thrombolytic after 12 hours. Okay, remember this. Now, as far as primary PCI is concerned, the new guidelines recommend up to 48 hours. There's a benefit of doing primary PCI. Earlier we used to tell 24 hours, but now they have extended to 48 hours, and they're saying some benefit is there up to 48 hours also. This is extended further if the patient is hemodynamically unstable, or the patient is having hypotension, or ejection fraction is low, or hypotension is there. They are saying even if you do after 48 hours, in a patient who's got hypotension or low ejection fraction or unstable patient, they'll still benefit. Third day, fourth day also they'll benefit. So I hope you understand. Thrombolytic door closes at 12 hours. 12 hours, khatam. Nail it up, finish, thrombolytic is out. But actually the studies are suggesting that after 3 hours, the risk-benefit ratio of thrombolytic is questionable. After 12 hours, can't give thrombolytic at all, whatsoever. In a primary PCI, earlier I used to tell 24 hours for thrombolytic. Recent guidelines have shifted to 12 hours. Primary PCI used to be 24 hours. They shifted to 48, and they're saying no time limit if the patient is unstable. Okay, 48 hours is basically the new cutoff for PCI. What else is there? What your question is? Can you repeat with patient with ST depression? Okay, in ST depression, this is basically NSTEMI you're talking about, correct? So in a patient who came with NSTEMI, what is the concept? Clot is forming, stop it from forming. In a patient with STEMI, clot are formed, only option is break it. Okay, give thrombolytic, go PCI. Medical treatment may not have much impact. Here, stop the clot from forming. How can you stop it? Antiplatelet, anticoagulation. These together are called antithrombotic treatment. Now, what are the changes recent guidelines are recommending? Since we plan to take the patient for angio based on refractory angina, avoid using morphine. We want to know if pain is there, because pain now is becoming an indication to urgently shift to cath lab. Avoid morphine. Use nitrates, but be careful. Nitrates have not shown mortality benefit, although nitrates are very good in decreasing the pain and decreasing the pulmonary edema, but may not have overall mortality benefit. It is used, but it's not the most important treatment, unlike antiplatelet anticoagulation, which is known as antithrombotic treatment. Will you use beta blocker? Definitely, but again here also it's oral beta blocker. Oxygen should be used here also, but only in patients with saturation below 90%. Okay, in the antiplatelet drug, aspirin definitely should be given as soon as the patient comes. In anticoagulation, unfractionated heparin is considered slightly better now, recent guidelines, compared to low molecular heparin. Earlier we used to tell low molecular heparin, now we're telling unfractionated heparin is better. They're telling don't give prasugrel before you take the patient to cath lab, because once you give prasugrel, let's say, in the cath lab you decide based on the anatomy the patient should go for CABG, then you cannot do now because your bleeding risk is very high. So they are telling many of these additional drugs to aspirin, if you can hold it until you can go to the cath lab, especially if you plan to do cath lab very early, then you can hold it, and intra-cath you can start, inside the cath lab you can start the antiplatelet drug based on the coronary anatomy. If you're convinced the patient only needs angioplasty, the answer is you can just start the antiplatelet drug and start the treatment. Anyway, what is immediately to be given is antiplatelet aspirin and unfractionated heparin. Don't use morphine, new guidelines, because if you give morphine, the pain will go away. You will not know refractory angina is there. Refractory angina means immediate shift the patient to cath lab and get an angioplasty done. So these are some of the things for NSTEMI. Point is, when you have a ST segment depression or T wave inversion, unless ST segment elevation is there, do not give thrombolytic therapy to this patient. Okay, so sometimes in the round somebody will tell, sir, so many days I have not given thrombolytic. Can I give to this patient? Okay, yeah, this fellow is just talking around, walking around nicely, he's moving around. Give thrombolytic. Let's see how he will survive intracranial hemorrhage. Okay, what's the side effect? Intracranial hemorrhage. If he is lucky, we'll see, test our luck and see. Okay, this fellow is talking too much, let's give thrombolytic therapy to him. I hope you understand what I'm trying to tell you. It's a dangerous drug. Unless really required, like a STEMI, don't give thrombolytic to patient. Okay, that's the important idea. Once the blood leaks out of the vessels in the brain, no force on earth can get it back inside the vessel. He's doomed, he's gone. Intracranial bleed is gone case. Localizing the MI, if you see inferior leads are showing elevation, 2-3 AVF. And the leads above are showing reciprocal changes. It is classical inferior wall myocardial infarction. Okay, sometimes you might see even lateral extension. So this is what we call infralateral wall MI. Okay, inferior leads are showing, lateral leads are showing, this infralateral wall MI. Okay, infralateral wall MI. In this ECG, you can see the lead 1 AVL is showing. This is lateral territory, and anterior also you're getting. So this is nothing but anterolateral wall MI. The two V5, V6 are lateral, V3, V4 anterior. So you're seeing now. So if you're seeing lead 1 AVL, V5, V6, this is what is lateral territory. This is lateral wall MI. If you see anterior leads V2 to V4 showing elevation, this is anterior wall MI. Okay, anterior wall MI, this is lateral wall MI. So you can make out lateral leads are positive, anterior leads are showing elevation. This is nothing but anterolateral wall MI. Main point is to differentiate pericarditis from MI. The main difference is if you are getting a ST elevation like this, which is concaving down, it's a MI feature. If you are getting an ST elevation that is concaving up like this, or has got a small positive deflection before the ST segment takes off, small positive deflection, then it went up. All these are markers of pericarditis. Okay, this is all nothing but pericarditis. This is what you get in pericarditis. And this is the kind of thing that you get in patients with acute MI. So concavity down, the patient is looking very sad, is leaving the world. The concavity up, this patient is looking happy because his time is still not come. This is now pericarditis. So concavity up, pericarditis. Concavity down, MI. So this is the main thing that you're looking for. Is the concavity up or down? Is the concavity up? It's pericarditis. Concavity down, remember, sad face, this is MI. Okay, so concaving down is going towards MI. So you can see over here, all these are patterns that are possible in MI. Okay, all these are possible patterns in myocardial injury. Okay, whereas if you see early repolarization, benign early repolarization, if you have this kind of a slope, this is inconsistent with myocardial injury. This is what we call early repolarization. This is known as benign early repolarization, which is a normal finding. Okay, this is not an MI feature. So I hope you can follow here. You can see this kind of a dip, and you can see it's kind of going like a concavity dip like this. This is reassuring. This is not MI. However, even if you get a pattern like this, but you are able to see a reciprocal ST depression in the opposite leads, always suspect possibility of MI. So features of pericarditis: concaving upward elevation, no reciprocal ST depression except in AVR, PR segment depression, TP segment downsloping. What is TP segment? The PQRST. This is PQRST. And then you have the next PQRST. This TP segment is downsloping. Okay, downsloping TP segment is a feature of pericarditis. If the PR segment, what is PR segment? After the P wave, the baseline, this PR segment is decreased compared to baseline. If this is the baseline, this is low. So a decreased PR segment, okay, you can make out a depressed PR segment is a feature of pericarditis. And third, you can see that in this case, one small positive deflection is there. That is reassuring to us. It means that this is not MI, it is pericarditis. This is called saddle shape elevation. Okay, our saddle is like this. this kind of saddle shape elevation if you're getting, then this is going towards pericarditis, it's not MI. So all these are features that are suggestive of pericarditis. Patient has new onset angina. Are any of these drugs suggested to be taken as precaution before reaching the hospital? So in a patient with new onset angina, the most important thing to do is rest and aspirin. Nitrates in a patient with stable ischemic heart disease will help because they open up the coronary vessel. In a patient with STEMI, the nitrates may not have much benefit because 100% occlusion already occurred. In a STEMI 100% occluded. So trying to get more blood by dilating the vessel in that local area will not happen. But yes, nitrates will reduce pain. Nitrates will reduce pulmonary edema because they are venodilators. They dilate the lower limb veins. They pull the blood in the lower limb, cause less pulmonary edema, less load on the heart. So in that sense, nitrates are useful. So in a STEMI, nitrates plus or minus. In a stable ischemic heart disease, yes, nitrates are going to definitely benefit. So I hope you understand the idea. Then aspirin is the most important thing because the propagation of clot we don't want. Okay, aspirin very critical. Nitrates also people can take before reaching the hospital. They will have some benefit, but more important is aspirin and more important is rest. Any patient who's got exposed to stress in his life, who can handle stress, or patient has got ischemic attack in the past, this is what his body's adaptation is known as ischemic conditioning. If ischemic conditioning means he's got exposed to a little bit of ischemia first and then one more attack occurs, he can handle it better. First time rupture of plaque, 100% occlusion, then that can be more dangerous. That can cause more damage. So as you know, it is basically adaptation that is what we want. Any ischemic conditioning, any adaptation is possible. Collaterals will have formed. That is actually generally turns out to be better prognosis. So is morphine used in stable angina? No, in stable angina we don't use morphine. In ischemic heart disease, acute coronary syndrome, there is a role of morphine, but it is used in STEMI. Okay, it is used in STEMI. In unstable angina and STEMI, if you are planning to take the patient to the cath lab, then you can give morphine. But if you are deciding to take the patient to the cath lab based on the angina, is it refractory or not, then morphine may hide the angina, so you will not know when to take the patient to the cath lab. So I hope you understood. In stable angina, no morphine. In acute coronary syndrome, in unstable angina and STEMI. What is acute coronary syndrome? One is ST segment depression or T wave inversion. This is partial occlusion. This is either unstable angina or STEMI. In these, morphine has a role. But the role is, in a STEMI patient though, you can definitely use morphine. Yes, 100% occlusion, ST segment elevation, you can use morphine. The pain will come down. Okay, you can use morphine. But here, morphine, if you are deciding to take the patient to cath lab based on the pain, and if you hide the pain, then you will not know when to take the patient to cath lab. If you are anyway decided to take the patient to cath lab, then you can give morphine, it will reduce the pain. Okay, that's the general idea. So how we choose the drug depends on how we are planning to further manage the patient. Localization of MI. Okay, V1, V2 ST depression. Okay, in a patient with inferior wall MI, V1, V2 depression can occur, but sometimes it can be posterior wall MI. Like in this case, actually what you're seeing is tall R wave, and you're seeing a flat ST segment depression with a upright T wave is classical picture of posterior MI. I didn't mention it because at your level they'll not ask posterior wall MI. Actually, this patient has got inferior wall MI, he's got lateral wall MI, but he's also got posterior wall MI. How can we tell posterior wall MI? If you look at the V2, you can make out that there are R waves. There is a flat ST depression actually suggestive of posterior wall MI, and the T wave is also inverted, right? Can you appreciate this upright T wave, because you're seeing from V2, if you flip this image and you see from the opposite direction, then what you will get, if opposite direction is, you will get a picture like this. This is classical ST elevation, which you are seeing. If you put a lead behind V9, V10, V7, V8, V9, sorry, you will get a true picture. This is posterior wall MI. This is clearly posterior wall MI. But since you are looking from the opposite direction, V1, V2 is showing like this. This is one of the ways to tell this posterior wall MI. So there is inferior wall MI, there is posterior wall MI, and there is lateral extension. So these are the types of MI that are there in this patient anyway. But I don't think they'll ask you at your level if you detect posterior wall MI. This is a postgraduate stuff. If you can detect, good. If you don't worry about it. They'll not ask posterior for you. But definitely inferior wall MI you should recognize. And if you can pick up lateral, that will be good. Okay, lateral wall MI is also there in this patient. right? So localization is mentioned here. 2-3 AVF is inferior wall MI, right coronary artery is the culprit. Okay, V2 to V4 is anterior wall MI and it is LAD territory. Okay, V1 to V4 also LAD. Lead 1 AVL, V5, V6 is lateral wall MI, left circumflex. Okay, any left bundle branch block is LAD territory. Okay, remember bundle branch blocks LAD, but AV node SA node problem right coronary artery. Okay, let me repeat, SA node AV node problem right coronary artery, but bundle branch block is LAD territory because LAD septum supply majorly LAD, so bundle branch blocks are LAD problem, left anterior descending problem. This also is not an MCQ zone for post MBS level. Okay, it may be asked in some platforms, but in the exam they may not ask you. Okay, what's the principle about reciprocal lead? See, reciprocal lead concept is, if you are looking at a patient who's got lead 1 AVL over here, okay, lead 1 AVL, okay, and you got inferior leads, okay, this is lead 3, AVF and lead 2, these are inferior leads. Remember, ST elevation has localizing power. If this area infarcted, the leads in front of it, they will show ST elevation. Whichever leads show ST elevation, that area is in front of it is damaged. The opposite leads will show reciprocal ST depression. Okay, the leads from above, they are seeing from the opposite direction, they will show reciprocal ST depression. The same ECD showing ST depression also, ST elevation also. Whenever ST elevation comes, the ST depression has no value for us. It's a mirror image seen by the opposite leads. This is what we call reciprocal change. Okay, does not have any localizing power. Look at the other way. Let's say if the infarction occurred in the lateral wall of the left ventricle. This is where the infarction occurred, lateral wall. Now the leads above will show ST elevation because the leads, they are facing the area that is damaged. This is ST elevation, this is lateral wall MI. The opposite leads, especially lead 3, which is most opposite, will show reciprocal ST depression. The more opposite it is, the better reciprocal change it will show. So a reciprocal change that is being seen here does not have any significance. It's simply a mirror image, but where the ST elevation is, that's where the damage is. Unlike a patient who's got this kind of a picture, you should know that when you're looking at a subendocardial infarction, okay, let's say the patient has got subendocardial infarction, not a transmural infarction, subendocardial, then if you see this area is showing ST depression, this is showing ST depression, this subendocardial infarction occurred. This is end-STEMI. This is what is happening in end-STEMI because partial blockage of coronary artery occurred. The problem is even the opposite leads also may show ST depression. ST depression, because the inferior leads also showing, superior leads also showing, you cannot now use ST depression to localize. So ST depression cannot have localizing power. I have seen some students telling that patient came with ST depression in lead 1 AVL and lead 2-3 AVF did not show any change at all. They are now telling lateral wall ischemia. Such a thing is not possible because ST depression does not have localizing power. The wall in front of it may be damaged, the opposite wall may be damaged, we can't say. Same way, if you get a subendocardial infarction, this end-STEMI, the patient is coming with ST depression in the inferior area. But actually this may not be true because sometimes, you know, the opposite damage also is seen by this as ST depression. ST depression does not have localizing power. It doesn't mean the area in front of it is damaged. It may be the opposite area that is damaged. It doesn't have any value. So ST elevation has localizing power. Whichever leads to ST elevation, the muscle in front of it is gone. Okay, so I hope you understood this idea. That's the concept of reciprocal change, and that's how ST elevation is important. So anywhere in the ECG, more than 2 leads show ST elevation, it is STEMI. 2 concurring leads, okay, are showing ST elevation, it is STEMI for us. ST depression in the same ECG does not have any value. It's a mirror image. In the heart failure, below 40% is basically heart failure with reduced ejection fraction. Above 50% is heart failure with preserved ejection fraction. And if the ejection fraction is normal, it's called mid-range ejection fraction. So that means some students have the wrong idea. They think heart failure means ejection fraction should be low. No. Heart failure can be anything. Many times I've seen students ask me, sir, how can a patient with hypertension have heart failure, or how can heart failure and hypertension occur together? When a patient has chronic hypertension, the ventricle undergoes concentric left ventricular hypertrophy, and as the ventricle undergoes concentric left ventricular hypertrophy, inner diameter becomes smaller and smaller and smaller. This ventricle becomes non-expansile, it's not compliant. Because of the cavity being less, the left atrium cannot put the blood inside, and the reason why heart failure occurs is the ventricle is unable to collect the blood. This is called diastolic heart failure, also known as heart failure with preserved ejection fraction, because the collection of blood is so low, end diastolic volume is so low, because what is ejection fraction? It is stroke volume divided by end diastolic volume. The end diastolic volume became so low that ejection fraction will come high. So this patient also has heart failure, but the reason for heart failure is not a pumping effect, is because of collection. He can't collect the blood, so heart failure will occur. Okay, this is called diastolic heart failure. It occurs with hypertension. So sometimes in MCQ they'll tell you patient has got hypertension, patient got raised JVP, pulmonary edema. What's your diagnosis? And I've seen students ask me this, sir, how can hypertension be there in heart failure? It is the hypertension that caused the heart failure. So that's why hypertension is still there. This patient has hypertension, but the patient simultaneously has heart failure, and this is what is called heart failure with preserved ejection fraction. So what are the features of heart failure? Raised JVP, hepatojugular reflux positive, third heart sound, shifted apical impulse, okay, cryptations, edema, and you know the dyspnea, orthopnea, PND. The treatment of heart failure is, at stage A only risk factors are there. In stage B, patient has echo problem but no symptoms. In stage C is what we see in our hospital. Echo is also abnormal, patient now became symptomatic. And stage D, patient has got refractory heart failure. So most of the patients that we see are in stage C. However, now we are saying that in stage A and B, you can prevent them from going from to stage C. And the best treatment that we do is risk reduction. Risk factors you reduce, but you start the patient on ACE inhibitors and beta blockers. Just by starting ACE inhibitors and beta blocker in stage B, there was a large study done in US that showed billions of dollars they could save just by starting the patient on ACE inhibitor beta blocker, because the conversion rate to stage C was significantly decreased. So there is a benefit of using ACE inhibitor beta blocker in the stage B, and you can reduce the risk factor and delay the progression to stage C. What is the treatment in stage C? ARNI. What is ARNI? ARB plus neprilysin inhibitor, which is valsartan sacubitril. Then you can use beta blockers, you can use diuretics, hydralazine, spironolactone. The new thing is SGLT2 inhibitor. Whether diabetes is there or not there, empagliflozin should be used in heart failure patients. Spironolactone is beneficial provided the patient's creatinine is less than 2.5 and potassium is less than 5. You can start a patient on spironolactone. Ivabradine is also approved in the treatment. So all these drugs are used in heart failure. Okay. Of these, clear mortality benefit is by ARNI, is by spironolactone and beta blocker. They are all showing mortality benefits. So ARNI is showing, beta blocker is showing, spironolactone is showing. What will be used in heart failure but does not have mortality benefit is the MCQ. The answer is diuretics. Last stage we can add digoxin in the treatment. Digoxin again does not have mortality benefit. Symptomatic benefit, last option. In a refractory patient, despite all this, still BP is not, the heart failure is there, then you can use digoxin. Digoxin will not have mortality benefit. Remember, digoxin and diuretics. So you might say even spironolactone is diuretic, not this. Loop diuretic do not have mortality benefit. Okay, they are used symptomatic benefit, not for mortality benefit. So this is as far as the stage C heart failure treatment is concerned. In arrhythmias, if you see fluctuating RR interval and if you see wavy baseline, this is atrial fibrillation. Unlike a normal P wave, a normal ECG like this, if you see wavy baseline, it is nothing but atrial fibrillation. Main drug in atrial fibrillation is control the ventricular rate. When you control the ventricular rate, sometimes AFib spontaneously reverts back to normal. You don't even have to start a rhythm reverter drugs. So if the MCQ asks you between rate control and rhythm reversion, which is better? Rate control is better. Which is the main drug? Beta blocker. If they cannot tolerate beta blocker, then go for diltiazem and verapamil. Do not use adenosine in atrial fibrillation. This is a repeat question in our exam. Don't use adenosine in atrial fibrillation. It's too short acting and it will work only for 10 seconds. After that, the ventricular rate will go back to what it was. So don't use adenosine. In the rhythm reversion, you can use ibutilide, amiodarone, prokinamide, all these. In any patient with atrial fibrillation, anticoagulation have to be started. Typically what we start is a direct oral anticoagulant agent because we don't want stroke to occur. But in patients with mitral stenosis and in those who got prosthetic valve, you cannot use direct oral anticoagulant agents, only warfarin is allowed. Not that the DOAC will not work here. They excluded MS and prosthetic valve in the DOAC study because this is very high risk of pulmonary of embolism, So they excluded them. That's why DOAC is not allowed. So in these two conditions, only drug allowed is warfarin. INI-CT asked this question, ki in a patient with MS with atrial fibrillation, which anticoagulation you will use? Will use apixaban, rivaroxaban, dabigatran or warfarin? The answer is warfarin. So MS with AFib, prosthetic valve with AFib, use warfarin, not DOAC. In a patient with atrial flutter, you will see flutter waves. Okay, you will see this continuous flutter waves without any stopping. So continuous P waves like this, flutter waves, is atrial flutter. Treatment is just like how we give treatment for atrial fibrillation. Same treatment you're going to use. Remember, any patient is hemodynamically unstable, you are going to go for shock. The systolic blood pressure is low, patient has loss of consciousness. That is unstable patient, you have to shock the patient. In order to deliver a shock, you can now give it synchronized or non-synchronized. Synchronized is called cardioversion. Non-synchronized is defibrillation. Every time we give a shock, when we synchronize it, obviously the machine will do it on its own. You don't have to do synchronize. It will synchronize it with the R wave. It will try to give a shock at the peak of the R wave. Non-synchronized shock is allowed only in two places, pulseless VT and ventricular fibrillation. Okay, everywhere else cardioversion. Only two places for defibrillation in the MCQ, pulseless VT and VFib. It is defib. Otherwise everywhere cardioversion. SVT, when you have to choose in the exam, be careful. The important idea is RR interval should be exactly equal. Any fluctuating RR interval, rule out SVT. So it should be narrow QRS. It should be narrow QRS. Usually the P waves are retro inverted P waves. You may see the retro inverted P waves, you may not identify them, doesn't matter. But the point is RR interval should be exactly equal. No fluctuating RR interval is possible here. Okay, so RR interval is equal. Inverted P waves are there, retro inverted P wave, and QRS will be narrow. These features are fulfilled in a tachycardia. It is SVT for us. So for a SVT patient, how do you want to treat? The treatment for SVT, first you do carotid massage. It doesn't work, then go for adenosine, 6 mg IV adenosine you give. Doesn't work, you can repeat by 12 mg IV. Still doesn't work, then you go for beta blocker, or you can even consider to administer a shock. Even though patient may be stable, you can still give a shock under sedation. Okay, if a conscious patient is there, stable patient, you can shock, but it should be done under sedation. Although typically shock is reserved for unstable patient, in some arrhythmias you're allowed to shock provided you do it under sedation. So here carotid massage, adenosine, beta blocker, shock is the next option. Once the patient comes out of it, then we want to prevent it further, then you put the patient on beta blocker and diltiazem. Okay, one of these two you're going to put to prevent the next episode. So the idea is, whenever you have a regular narrow complex tachycardia, if the patient is hemodynamically unstable, then the answer is cardioversion. If the patient is hemodynamically stable, first try vagal, carotid massage. That doesn't work, go for adenosine. That is ineffective, then go for either beta blocker or diltiazem. If that is also ineffective, then you can try antiarrhythmic drugs. Okay, if nothing is working, they can take the patient to the cath lab and ablate the area which is triggering the arrhythmia. So this is the step-by-step management for a narrow complex tachycardia, like an SVT. Okay, unstable patient, cardiovert. Stable patient, go for vagal first, adenosine. That doesn't work, go for diltiazem or beta blocker. That doesn't work, go for antiarrhythmic drug. If you're looking at a patient on WPW, the P wave will not have a flat line after it. It will have a delta wave. Okay, you will have this delta wave. So you should not get a flat line between the P and the QRS. That delta wave should be there. That's a must for you to tell WPW. So WPW, PR interval is short, QRS is broad, and delta wave will be present. Okay, does Valsalva have any role? Yes, Valsalva is a type of vagal maneuver. Okay, so vagal reflex includes carotid massage, includes Valsalva, okay, includes putting cold water on the face. So patients themselves would have found some technique that works for them. Some patients tell, when I am holding my breath, I become better. Some patients tell, when I put my head between the two legs, I become better. Some patients tell, when I am putting cold water on my face, then I become better. Basically, it's a vagal technique they are having. Sometimes in our hospital, you will see our nursing staff is giving a syringe and ask the patient to blow through the syringe. Again, they are kind of doing a Valsalva-like picture. That's a vagal technique. So WPW syndrome, three things: short PR interval, broad QRS, delta wave should be there. Two types, type A, type B. The most common type is type A, which is present on the left side, accessory pathway. Between right atrium and right ventricle is rare, it is type B. Treatment is class 1A, class 1C, class 3 antiarrhythmics. And the treatment is radiofrequency ablation, especially if the patient had a a dangerous arrhythmia on top of the WPW in one episode occurred, then the patient should go for radio frequency ablation. The ECG for WPW is very easy. You can recognize that there is no flat line between the P and the QRS. As soon as the P finished, the delta wave is there and the QRS is starting. Okay, this is classical for WPW. In a patient with VT, if it lasts for more than 30 seconds is sustained VT, less than 30 seconds is non-sustained VT. So you can make out the QRS complex replicates. There is no variation at all in them. This is known as monomorphic VT. Okay, this is referred to as monomorphic. No change in the morphology. Same QRS again and again and again and again. Monomorphic. So this is a very classical monomorphic VT that you are recognizing. In a single lead, it will not change the shape. The treatment is procainamide and amiodarone. Lignocaine may not work for most patients. It works only for 25% of patients, but the advantages is fast. It's fast. Sometimes you want to try lignocaine in an unstable patient, you can try. The only benefit is very fast, but it may not work in majority. What will work in majority is procainamide and amiodarone. If a patient has polymorphic VT, the reason for that is long QT. So when patients have long QT, they can develop polymorphic VT. The long QT, how it occurred, may be acquired, maybe it is congenital. If polymorphic VT has occurred, then you get this very classical feature called torsade. What is torsade is, you get low amplitude, low amplitude, then high amplitude. You are noticing an alternative pattern. You see large amplitude, small amplitude, again large amplitude, again you will see small. So it is alternating like this. This is known as torsade. When you get a torsade, it's classical for polymorphic VT. What you want to do in this patient is immediately give magnesium sulfate, MagSulf in acute patient. If the patient is unstable, you might have to also shock the patient, especially if it's pulseless, then it's defibrillation. With pulse VT, the answer is going to be cardioversion. So you have to shock the patient. How do you prevent the next episode? In a congenital long QT, the answer is beta blocker. They asked in the exam, don't choose pacemaker and all that. Better answer is beta blocker, congenital long QT. Acquired long QT, you find the cause and remove it. What drug is causing it? You have to find that drug and remove it. If hypokalemia is causing it, treat hypokalemia. Hypomagnesemia is there, treat hypomagnesemia. Treat the electrolyte and remove the drug. If patient has no pattern should be there in the entire ECG. Random scattering of current. This is ventricular fibrillation, no QRS. This patient should go for non-synchronized shock as the first step. And remember, shock is the one that will revert the patient back to normal. You may do chest compression, but may not have much benefit. Its only benefit is it will keep the brain alive. Okay, that is also must, isn't it? But what will get the patient back to normal actually is shock. The faster you administer the shock, the more likely the re-entries will go away and the normal conduction across the heart will start. So non-synchronized shock, that is defibrillated shock, should be given as early as possible in a patient with ventricular fibrillation. However, if you have a patient with a flat line, there is no re-entry inside, shock will not work. Shock only works for stopping the re-entries and homogenizing them. This is not a shockable rhythm. So when you have a flat line, do not administer shock for the patient. Only thing you can do in this patient is the chest compression. So start chest compression with ventilation, ratio is 30:2. Keep the chest compression rate at 120 per minute and make sure the depth of the chest compression is 2 to 2.4 inches or 5 to 7 centimeters. Okay, that's the depth in which you're pushing the sternum. When you look at a heart block, a type 1 heart block is a prolonged PR interval. In a type 2 and type 3 heart block, you get something called group beating. What is group beating is? In between 1-1 the beat will not come, QRS will not come. This is known as group beating. So you will see a group of beats and in between you will see some missing. What is that is? You can see 2-3 beats are there, gap occurred. Then again you will see 2-3 beats, again gap will be there. This is what we call group beating. Now the basic difference between the 4 heart blocks, they'll give you these together in the exam. They'll give you type 1, they'll give you Mobids 1, they'll tell you Mobids 2, and they'll tell you type 3 heart block. Whenever you get this kind of question where they're giving you these 4 blocks, type 1, Mobids 2, Mobids, type 3 heart block, then the approach is very simple. First thing you find is the patient having equal RR interval or not. The moment you have RR interval is equal, no fluctuating RR interval equal, you are looking at either a type 1 or a type 3. Mobids will never come with equal RR interval because you are getting a gap in between. One of the QRS did not come. So the moment you see RR interval is unequal, you have got to choose from Mobids 1 and 2. If you find RR interval is equal, your answer is between 1 and 3. The only difference is in type 1 heart block, for every QRS, there should be only one corresponding P wave. and it should be at a fixed gap between the QRS and the P wave. There should be a fixed gap, and this is what we call prolonged PR interval. Okay, from the starting of the P till the starting of the QRS, this is prolonged. So more than one large box if you're getting from starting of P to starting of QRS is prolonged PR interval, that is type 1 heart block. For every QRS, only one P will be there and it will come with a fixed gap between the two. Whereas if you're looking at MOBITS 1 and MOBITS 2, RR interval is not equal, that's the first step. Secondly, the PR interval became longer, that compared to the next one became even more longer. Then P occurred, no QRS, again it will start with a short cycle. So if the PR interval is changing, MOBITS 1. If the PR interval is fixed, no change in PR interval, after that P came no QRS, that is MOBITS 2. So that's how you differentiate. Finally, if you're looking at complete heart block, remember the RR interval should be exactly equal. Any fluctuating RR interval, kick out complete heart block from your answer list. You may or may not be able to identify all the P waves. If you can identify the P waves, good. If you don't worry about it. If you find a fluctuating PR interval with the equal RR interval, you are safe in telling complete heart block. So you can see the PR interval is changing. It's not the same. Okay, in fact here the P is occurring in the QRS. Okay, here is occurring so short. This is not type 1 heart block, and plus there will be bradycardia. As you can see, more than 5 boxes between two R wave is bradycardia. So PP interval is equal, RR interval is equal, atria is beating at a separate rate, ventricle beating at separate rate, no relationship between the two. This is a complete heart block. Now here is the important idea. Again, RR interval is unequal, choose MOBITS. RR interval is equal, choose type 1 or type 3. In type 1, for every QRS only one P wave and it will be fixed gap every time. In a complete heart block, you will not notice any gap, or rather you will not notice a fixed picture, because look here, this PR interval is this. This time you can see PR interval is so short. So changing PR is, there's no relationship between the P and QRS, it's a complete heart block. So that is how the approach should be. So the more simple you keep it, the more likely you're going to get the questions correct on heart block. In a patient with Takotsubo cardiomyopathy, it's high catecholamines that are there, triggered by either emotional stress or any stress that cause the infundibulum. The infundibulum is the area just below the aorta to go into spasm. When this area goes into spasm, it creates a LVOT obstruction. Left ventricular outflow is blocked. The rest of the myocardium gets stretched and damaged. This area gets stretched and damaged. When this is stretched and damaged, by the time the patient comes to us, the only area that is normally contracting is the area that triggered the problem in the first place, that is basal area is nicely contracting. The mid and apical segment got stretched and damaged, it's not contracting. So mid and apical area hypokinetic, basal area hyperkinetic. That is a classical picture of Takotsubo. The problem with Takotsubo is sometimes mistaken with ischemic heart disease because they will show STT changes, chest pain. Many times the MCQ will trick you by telling ST elevation. But the clue for us is when you do the coronary angio, in a ST segment elevation, you are expecting 100% occlusion of the coronary artery. Then only transmural infarction, ST elevation will occur. But when you see ST elevation and you do the angiogram, angio may be normal or mild atherosclerosis may be there, some 20% occlusion, let's say. Any normal person on the footpath you pick up and you do angio, you may get 20% occlusion. So I hope you understand this idea that when you see STEMI, you expect 100% occlusion. So some normal or mild atherosclerosis, it indicates it's not a STEMI. This is nothing but Takotsubo. Here troponin also may be high. Okay, you may see even the troponin is increased. So even if the troponin is increased, it doesn't have any change in the answer. The patient is not having the angio to support a STEMI. So this is nothing but Takotsubo. So what do you want to do in this patient? The ventricle is not contracting properly. It will begin contracting soon, so just need to give rest to the patient, and the treatment is AC inhibitors and beta blocker. So just give AC inhibitor, beta blocker, patient will improve. Okay, generally the prognosis is good. This myocardium is alive. Its perfusion also is normal. In fact, we proved it by angio. Perfusion is okay. That's why it's called stunned myocardium. So by definition, a stunned myocardium is one that is alive, which is not contracting, but the coronary blood flow in that area is good. That is called stunned myocardium. So the Japanese use this instrument to catch octopus. This is how it will look when you do the ventriculogram. The basal area is hyperkinetic, so it will appear narrow. The mid and apex is not contracting. Because of that, you will see that is dilating up like this, and this is how it looks. That's why it's called Takotsubo. Okay, this Takotsubo is this thing that they use to catch octopus. In a patient with HOCM, it is a family history is there, genetic involvement is there. Echo will show something called SAM, systolic anterior motion of mitral valve. An MR may occur in this patient. Muscle fiber disarray. This is by very nature of the muscle, this is highly arrhythmogenic condition. Okay, the way the muscle fiber is arranged, this is highly arrhythmogenic, fertile ground for arrhythmias. So even if the patient does not have occlusion, blockage in the septum, sometimes they just throw arrhythmias. So you have to be careful about this patient. They may have sudden cardiac death. This more commonly occurs when the patient is exerting on the football field, fellow is playing, he may suddenly develop an arrhythmia and he'll die. The trick question they played in our exam, INICT asked a question. What they did was they gave the image of HOCM, patho image. Everybody saw the thick asymmetric septum and became very happy. They recognized HOCM. The question they asked was tricky. They said, this patient died, this is autopsy specimen, what's the most likely cause of death? Septum causing occlusion and decreased perfusion of brain. Septum causing occlusion and resulting in MI. Ventricular arrhythmia. These were the choices that given, ventricular arrhythmia. And the correct answer is ventricular arrhythmia. The cause of death usually in this patient is ventricular arrhythmia. So don't answer septum blocking or heart failure occurred or a stroke occurred or whatever. The correct answer actually is arrhythmia. Arrhythmia is the main cause of death in this patient. What type of arrhythmia? Ventricular arrhythmias are common in HOCM. Interesting thing is about the murmur. Murmur increases on Valsalva standing and nitrate, and generally the idea is more blood should come with more murmur. Here ulta, here more blood will come with less murmur, less blood will come with more murmur. So when the patient stands, LV has less blood and less blood, more murmur. Valsalva, you raise the pressure inside the thorax, press the heart from all direction, LV will feel less filling, but still murmur is there. So basic idea, less the end diastolic volume, less the blood in the ventricle, the louder the murmur. This is peculiar to cardiology because normally more blood you collect, more blood you push through the damaged area, more turbulence it should create. But HOCM is ulta, less blood, more murmur. Treatment is beta blocker, disopyramide. You can use diltiazem, but never use drug like nifedipine or amlodipine. You can inject alcohol to shrink the septum, and you can do septal myectomy, and you can even take the patient for an ICD if you are worried about dangerous arrhythmias. The new drug in this is mavacamten. Mavacamten is basically targeting, it's an inhibitor of cardiac myosin, and it is reducing the myosin actin bridges and decrease contractility. So basically that hypercontractile state that HOCM has, it will reduce that. So this drug is showing good promise, and it is one of the important drugs that they may ask you in the exam because this is approved in patients with HOCM, mavacamten. So again, what is mavacamten? It is basically helping in the relaxation of the muscle. It helps in better relaxation of the sarcomere and thereby improves the echo function. Echocardiogram function becomes better. Okay, that is the benefit of using mavacamten. Moving to the rheumatology, if you look at large vessel vasculitis, medium sized vessel vasculitis and small vessel, the very nature of what area that vessel is will give you an idea what they can manifest in. For example, a large vessel vasculitis cannot come with diffuse alveolar hemorrhage. They cannot come with glomerulonephritis because they involve large vessel. Okay, for that glomeruli to be involved, for alveoli to be involved, it must be a small vessel vasculitis. If it's a medium sized vessel vasculitis, you're dealing with polyarteritis nodosa and Kawasaki. So in an SVT, I've seen students ask me, sir, how do you decide whether it's an inverted P wave you're dealing with or is it a inverted T wave? Now, in a known tachycardia, we are already aware there's something called SVT. And we know in an SVT, we are anticipating the P to be inverted and, retro inverted. It should occur after the QRS should be inverted. And if it were to be a normal rate, normal heart rate, and the patient had a T wave inversion, then I would have thought this is a T wave inversion, right? But this is not a normal heart rate. This is a patient who's coming with a heart rate anywhere between 150 to 250 per minute. So let's say the patient has got a 200 beat, 200 per minute, and this narrow QRS with equal RR interval, I know this is an SVT, then why will I mistake that for a T wave? Because I am anticipating a P wave over there. Had it been a normal rate, I would have thought, okay, that's nobody can tell whether maybe it's a T wave. Why should we tell it's an inverted P wave? So I hope you understand that is a known pattern that is supposed to occur in a arrhythmia. Okay, at a 200 rate, for example, you're not thinking that's a T wave. And carefully, if you see actually after the P wave, you'll be able to see the T wave also. You'll be able to see an upright T wave also in this patient. So coming back, if you see a vasculitis, large vessel, medium sized vessel, small vessel. So the broad idea is large vessel means aorta and its branches will be hit. So carotid artery will be affected, TIA can occur, subclavian affected, arm claudication can occur, renal artery, hypertension. So when you say large vessel, aorta and its branches are going to be affected. These are the main symptoms. If you see medium size like PAN, like polyarteritis nodosa, then digital gangrene, gangrene of the digits, bowel ischemia, mononeuritis multiplex are classical features. So the broad concept also, if you have key large vessel, this is what I'm expecting, because the way where the vessel is, this is medium sized, and small vessel will come with small capillaries affected, so alveoli will be involved, glomeruli will be involved, skin purpura can occur, this small vessel vasculitis. So a general concept also, if you have, even before you go to specifics, even the MCQ asks you, can a patient with say Takayasu, can this patient come with glomerulonephritis? You can automatically say no, glomerulonephritis, you need small vessel. Okay, can a patient with Takayasu come with skin lesion? No, skin for it to be involved, it should be small, or sometimes medium maybe, but definitely not large vessel for skin involvement. So skin rashes, skin problem will not occur. So a broad idea, even before you look at the specific, you can have just by knowing the classification. Okay, what large vessels will do, what medium size will do, what small vessels will do. When you see Takayasu, it's a disease that occurs below 60 years, below 40 years, sorry. Okay, this is generally a disease that might start in the teen years. So teen years, early 20s is the age group. Because typically it involves the aortic arch and subclavian, patient will come with claudication pain in one arm, usually. When you check the two pulses, there will be asymmetric pulses. You check the blood pressure, they will differ by more than 10 mm mercury, indicating aorta and its branches initially are having a problem. If you auscultate over the subclavian or the aorta, you may get a bruit. And the common features that Harrison is telling, this is Takayasu. The first 3-4 things, if you know, you can know how to will construct a question. Subclavian most common affected, patient come with arm claudication. Common carotid commonly involved, so patient come with TIA, visual changes. Bowel ischemia can occur in this patient, so abdominal pain. Renal involvement, so hypertension and creatinine will rise. And aortic regurgitation. Usually these 4 or 5, if you know, the common thing that can occur in Takayasu. But what will alert you is the difference in blood pressure in the two upper limb, and the patient will come with claudication pain in one of the limbs, upper limb, difference in pulses, the two pulses are not equal, and difference in blood pressure more than 10 mm. That generally is the hallmark to tell you you're going towards Takayasu. But these are the common features that can occur. Okay, is Brugadas important? Yes, it is important. So that I have covered in the vibe session. You can take a look at the vibe session. It will give you all the important ECGs that are necessary. Okay, so Brugadas is nothing but in the V1 and V2, you will get concave, this kind of curved ST segment elevations. Okay, in V1 and V2, you will get something like curved ST segment elevations with an inverted T wave. This kind of coving, curved ST elevations in V1, V2 in an otherwise normal looking ECG is what you call Brugada. And this Brugadas is a sodium channel defect, high risk of the patient developing dangerous arrhythmias. Okay, these patients can develop dangerous arrhythmias. This is what you get in Brugadas. High risk of dangerous arrhythmias. Sudden cardiac death can occur. Patient can just throw an arrhythmia and he'll die. Entire ECG looks normal except for V1, V2 will show curved ST segment elevations like this. Okay, that is Brugadas. So temporal artery, the main features for temporal artery for us are these. They'll tell you a elderly person above 50 has to be above 50. And if somebody is getting migraine from 30 years, that doesn't count. It should be new onset headache that started above 50. Patient may have jaw claudication. When he's chewing, he may get pain, and the ESR should be above 50. Okay, ESR must be above 50. So 250s to remember, ESR above 50, age above 50. With headache, you're looking at temporal arteritis. Your biggest concern is this patient can have sudden vision loss because they are prone for developing anterior ischemic optic neuropathy. What is the next step? The moment you see these 4 things, they'll ask in the exam, what do you want to do next? The next step is start steroids. Immediately start steroids. Why are we panicking and starting steroids? Patient just has got headache, jaw claudication, ESR is high, that is there. Why are we so worried about steroids? We want to prevent vision loss. This vision loss in a minority is reversible, majority it's permanent. Okay, 10% of the time it may have vision loss and they may recover. 90% will have permanent vision loss, so start steroids. But starting steroids is not the end of the thing. Electively get a temporal artery biopsy done. So get a temporal artery biopsy done. If the temporal artery biopsy confirms the vasculitis, then the patient should be on steroids and tocilizumab in the treatment. Okay, steroid tocilizumab should be given in the treatment. So this is the plan. Of all the questions, if you see the last 10 years, most repeated question, patient came with headache, he's 70-year-old patient, ESR is 70, what do you want to do? Start steroids. After that, what do you want to do? Temporal artery biopsy. If the temporal artery biopsy shows vasculitis, then what? Then the patient should be getting steroids and tocilizumab in the treatment. So this is all the features. So generally it is common in female to male ratio is 2:1. Okay, female to male ratio is 2:1. Above 50, ESR above 50, face, so you notice all FFF, okay, above 50, ESR above 50, face pain, fever, the temporal artery will be firm and tender. It is associated with polymyalgia rheumatica. What is polymyalgia rheumatica? Patient has severe proximal muscle pain and stiffness. They cannot lift their hands up. Okay, you cannot expect the patient to lift their hands up like this. That is known as polymyalgia rheumatica. Okay, you ask the patient to raise the hand, they cannot. You ask the patient to get up from a chair, they'll have difficulty. But the CK levels are normal. That's how you differentiate from myositis. Okay, ESR is high. Treatment is steroid, tocilizumab, and follow up for next 5 years. Why are we following up? Because these patients are high risk of developing aortic aneurysms and dissection of aorta. Okay, they will recover from temporal arteritis, but long-term complication develop aortic aneurysm and they'll have dissection of aorta. That's a problem. Polyarteritis nodosa is a medium-sized vessel vasculitis, and because it's a medium-sized vessel vasculitis and does not involve small vessel, lung is spared. That's the most repeated question in our exam. There's no glomerulonephritis, although renal artery branches are involved, kidney is affected, but there's no glomerulonephritis. And the patient does not have any ANCA association. No P-ANCA, no C-ANCA. Remember, in PAN and HSP, there's no ANCA association. These patients will come with mononeuritis multiplex. Random patchy involvement of the nerves will occur. It is associated with hepatitis B. What are the main things over here? These patients will come with renal artery involvement. So renal artery branches are affected. So you will see increased creat and hypertension. Almost all patients will have. Patients will have myalgia, arthralgia and all that. They'll have mononeuritis multiplex. Common perineal palsy is very commonly described in our exam. The foot drop will be there. And the patient can have some skin lesions. So those are the main features, and you can see the table given by Harrison. They'll have renal involvement, arthritis, mononeuritis multiplex, so foot drop, radial nerve palsy commonly described. Bowel ischemia can occur, and they can have a skin rash. Classically it is livedo reticularis. And after all this, gangrene of the digits, finger gangrene, very classical in polyarteritis nodosa. Okay, gangrene of the digits. What is not involved? No lung manifestation, no pulmonary manifestation in polyarteritis nodosa. So among the ANCA associated vasculitis, you have MPA, GPA and EGPA. Okay, GPA is Wegener, EGPA is Church-Strauss, and MPA is microscopic cholangitis. Broad idea is that among the three, all of them will involve the lung and the kidney. But the difference is if ENT is involved, ENT and eye problems are there, it is Wegener. Okay, so sinusitis will be there, scleritis can occur, conjunctivitis can occur. So eye and ENT problem favors Wegener's. Among the three, between the Wegener, that is GPA, and MPA and EGPA, I told you ENT problem, sinusitis, okay, particularly sinusitis is a feature in favor of GPA, does not occur here. Although in patients here you can sometimes see rhinosinusitis, okay, or allergic rhinitis, allergic rhinitis, okay, allergic rhinitis. Nasal polyps sometimes can occur over here, so be clear, it's not that upper respiratory never involved in EGPA, it can be. If you see the pulmonary manifestation, you will see this patient will have cough and the X-ray will show cavities. If you see diffuse alveolar hemorrhage and hemoptysis, or if you see asthma, this will help you differentiate. So you get asthma here, you see diffuse alveolar hemorrhage and you see cough and cavities. In general, most of the PAN features like mononeuritis multiplex or livedo reticularis, everything, a lot of things look like PAN over here. But the difference is PAN does not come with asthma and does not have eosinophilia. So a lot of PAN-like features you can get in patients with EGPA. Mononeuritis multiplex can occur, livedo reticularis can occur, but you don't see asthma and eosinophilia. So these are the differentiating features that you should focus on. To summarize then, How patients with vaginous will come? Upper respiratory tract, lower respiratory tract, renal. Renal is there in all three. Difference is upper respiratory tract. Sinusitis, saddle nose deformity, classical for vaginous. MPA will not have all that. They'll have diffuse alveolar hemorrhage and renal involvement. Church-Strauss will have asthma, eosinophilia. They'll have mononeuritis multiplex, and they'll have allergic rhinitis. They can also have the skin involvement, just like PAN. So this is there in PAN, this is there in PAN, and also these patients can have bowel ischemia. So this is also there in PAN. So notice a lot of PAN-like features are there. Okay, all these are PAN-like features. Okay, this PAN-like features. So how do you differentiate polyarteritis nodosa from Church-Strauss? The difference is asthma, eosinophilia. No lung involvement in patients with PAN. Remember that. So bowel ischemia occurs there also, here also, skin here also, there also, and mononeuritis multiplex occurs in both. The treatment in all these three: steroid rituximab, alternative treatment steroid cyclo. You can use methotrexate for maintenance. Mepolizumab is additionally used for Church-Strauss. Okay, so main drug in all of them is steroid rituximab combination is the first line treatment for all of them. Avocapan is the new drug. It is basically a complement 5 inhibitor, and it is showing very good benefit for all the ANCA associated vasculitis. So there is some complement role in this condition, which you can block by using this drug, avocapan. Henoch-Schönlein purpura is a patient who will come with a skin rash. They'll have knee and ankle arthritis. Knee and ankle will be involved. They'll have abdominal pain. Okay, abdominal pain and diarrhea. Okay, because of bowel ischemia, they'll have abdominal pain and diarrhea. So rash, ankle knee involvement, abdominal pain and diarrhea. I think NEET or INICT asked the question. They said rash is there, ankle arthritis is there, abdominal pain with diarrhea is there. What's your next investigation? Many students could not connect what are they talking about, which is the disease. The thing is, we are so used to expecting that they'll tell purpura so that happily you can answer palpable, Henoch-Schönlein purpura. They'll not give you a gift, bhaiya lelo, purpura is there, answer is HSP. No. They just told rash, ankle arthritis, abdominal pain with diarrhea. What's the next investigation? This is HSP, and the next investigation that you should do is skin biopsy. If the skin biopsy immunofluorescence shows IgA deposits, you got the diagnosis of HSP. Okay, that is how you would make the diagnosis of this condition. Get a skin biopsy, IgA deposit you should show in immunofluorescence. The purpura here is not because of low platelet. Petechiae purpura can occur in thrombocytopenia, that is non-palpable. This is palpable purpura. Treatment is again steroids. Kawasaki's is seen only in children. Never occurs in adult because endothelium changes as we grow up. It never occurs above 15 years. These patients will get coronary artery aneurysms because they have anti-endothelial antibodies. This condition has anti-endothelial antibodies. So the main problem is the myocardial damage that these children are prone for. The criteria is the patient should have fever. Okay, unexplained fever should occur for more than 5 days. Then the patient should have some oral problems like dry cracked lips or strawberry tongue. Don't worry about others, they'll not ask. Then the patient should have conjunctivitis, cervical lymphadenopathy, polymorphic rash in the trunk, and you can get either swelling of hands and feet or desquamation of the hands and feet. Okay, peeling of the hands and feet or swelling of the hands and feet. These are main features that occur in Kawasaki. Fever is essential. You can get either dry cracked lips, okay, conjunctivitis, lymphadenopathy, rash, and you can see these patients coming with desquamation. So out of these out of the remaining 5, 4 should be positive plus fever should be there. Then you diagnose Kawasaki. Now in an adult, when you do echo, you can't see coronary arteries. Good thing for us in children below 5 years, this is occurring below 5 years, children, echo will show coronary artery. You don't have to do angio or CT or something. Echo itself will tell us whether the coronary artery aneurysms are there or not there. So you look, are the patient already having coronary artery aneurysms? Okay, remember that in children only you can see coronary artery aneurysms in echo. In adult you can't see coronary outflow. So the main treatment in this patient is, these are preformed antibodies. The patient has anti-endothelial antibodies. So steroids may not give you much benefit here because these are preformed, just like GBS, they already formed antibody. They'll go and attach to more endothelium in the coronary vessel and damage more. Before they can damage more, you have to remove them. Problem is below 5 years, plasmapheresis can't be done. So what you can do is neutralize by giving IV immunoglobulin. Already many of them will have coronary artery aneurysms, so we have to take care of that, so we give them aspirin. So a primary treatment is aspirin immunoglobulin. Now There are two more drugs that you can consider. One is steroids, one is warfarin, and they are dependent on how the MCQ describes. If the MCQ says patient has fever for more than 3 weeks, which is very rare in Kawasaki, but if the fever extends for more than 3 weeks, it's an ongoing immune problem, means fresh antibodies may form, so now you can give steroids. If the patient has large coronary artery aneurysms, echo showing large coronary artery aneurysms, aspirin alone may not be enough, because if you get stagnation of blood, clot can form. Then warfarin also has a role. So based on how they describe, primary treatment is aspirin immunoglobulin. But additionally, if they say fever lasted for 4 weeks, start steroids. Patient has large coronary artery aneurysm, then you have to consider warfarin in the treatment, because large aneurysm, blood will stagnate. Any stagnation of blood, clot will form. So you have to start anticoagulation. So what additional drug between these two will choose depends on how they describe in a question. Okay, so look at the question carefully and then choose the drug. In general, steroid is not an answer you want to go for, because usually Kawasaki, fever will go away in 1 or 2 weeks. Okay, it will rarely ever go beyond 3 weeks. Systemic lupus, these are skin problems that can occur. You can get acute, you can get subacute, where you can see annular psoriasiform rash, or chronic, the patient can get discoid rash. These patients can have oral nasal ulcers, non-scarring alopecia, arthritis, serositis, renal involvement, neuro involvement, and blood involvement. All these are criteria. AIMS asked a question, which single criteria if is present, it's enough to make the diagnosis of SLE. You don't need so many. Normally you need 4 criteria. One criteria if it's positive, it is SLE. What is that? The answer is renal artery biopsy. Renal biopsy. If the renal biopsy is suggestive of SLE, this is now patho-proven condition. You don't need anything more. If you see wire loop lesion subendothelial, it is classical for SLE. You don't see it anywhere else. So once renal biopsy is suggestive of SLE, you don't need all the criteria. It is SLE for us. Lab criteria is ANA, double-stranded DNA, anti-Smith, anti-phospholipid. Lot of patients we see in our OPD who are so scared about SLE because this is not a condition that will go into remission. Lifelong they have to bear it. So sometimes people get a rash and they come running because they are scared it's SLE. 2 things you do, 100% you can exclude SLE. What are the 2 things? If the patient got an ANA done and anti-Rho antibodies. What is anti-Rho antibodies? It used to be, it was called SSA, Sjogren's syndrome A, but it is seen in SLE also. If these 2 antibodies are negative, you can 100% reassure the patient you don't have SLE. Okay, 90% are covered by NA, remaining 8 to 10% are covered by anti-Rho. Both are negative, it is not SLE. Okay, definitely you can rule out SLE. So these are a further workup that we do, and the criteria is total 4 criteria should be fulfilled of all these. Every patient with SLE should be on HCQs. Additional treatment is if the patient is organ threatening, steroid immunosuppressive therapy, but the MCQ is expected on this only, anifrolumab. What is anifrolumab? Only new drug now. It's anti-interferon treatment. Okay, anifrolumab is anti-interferon treatment. They may ask this in the exam. Okay, this is important. Okay, anifrolumab. In the last so many years, this is the only new drug they have added. So if the patient, every patient with SLE gets HCQ, hydroxychloroquine. If life-threatening, organ-threatening, steroid plus immunosuppressants you start, and anifrolumab is a new drug that they are talking about now, that you should know of. Patient with scleroderma, this is systemic sclerosis, remember. Systemic sclerosis can be divided into 2 types. Either it is limited or it is diffuse. Limited is called CREST, diffuse is called, simply as the name is suggesting, diffuse SS, diffuse systemic sclerosis. How to differentiate is the antibody, anti-centromere antibody, anti-SCL17, RNA polymerase 3 antibody. This antibody many people did not know, they asked in the exam. RNA polymerase 3 antibody, where is it seen? It is seen in diffuse systemic sclerosis. Big difference is these patients die of interstitial lung disease. Interstitial lung disease doesn't occur here, but both will have pulmonary hypertension. Raynaud phenomena occurs very early here. It's a late manifestation in patients with systemic diffuse type. Very early, years before the skin involvement, you can get Raynaud phenomena in CREST syndrome. AIMS asked a question, somebody comes to you with Raynaud's. In the future, you may worry that the patient can develop CREST syndrome. He can't develop diffuse systemic sclerosis because in diffuse, Raynaud and skin fibrosis occur together. Somebody is coming only with Raynaud, they may have idiopathic Raynaud, or your worry is they may develop CREST syndrome next year. What investigation will you do? That's the question they ask. What investigation will you do to pick up possibility of Crest syndrome? And the answer is you want to examine the nail base. Just below the nail base, you amplify, you magnify, and you see. Normally, the capillary should be hairpin appearance. This hairpin appearance is lost and the patient develops something called periungual telangiectasia. This previous year AIMS question, periungual telangiectasia, if you see with Raynaud's, we know this fellow is going to develop Crest syndrome in the future. Okay, Crest is coming. So in a patient with Crest compared to a patient with diffuse type, is it involving only the distal acral areas, or is it involving the arm, the trunk, the thigh? Anytime the disease goes above the arm, below the neck, above the knee, trunk is involved, the answer is diffuse. Only distal areas are involved, it is Crest syndrome. So there is a difference between Crest syndrome and diffuse systemic sclerosis. These patients are prone for GI manifestations. The classical is GAVE. GAVE is gastric antral vascular ectasia. That will bleed and the patient will get chronic melena, going for anemia. Diverticulosis can occur. Raynaud's phenomena, first drug calcium channel blocker, rest of the drug they don't ask in the exam. First drug is calcium channel blocker, you should know. Cause of death is pulmonary involvement, and until pulmonary involvement is there, don't use steroid. One interesting idea, if you use steroid in diffuse systemic sclerosis, the patient can develop something called renal scleroderma crisis. So we are not in a hurry to use steroid. In Majburi, last resort we use only when the patient has pulmonary involvement. Steroids are used. Otherwise, we try to manage pulmonary involvement also by using nintedanib, tocilizumab, immunosuppressants. Nothing is working, then we add steroid. Steroid will work because this is NSIP pattern. But the problem is if you use steroid, patient has high risk of developing renal scleroderma crisis. Okay, renal scleroderma crisis can occur. So don't use steroids in patients. By the way, steroids have no role in preventing the skin fibrosis in this condition. So for the skin, what do you want to do? Methotrexate. Okay, there is some study showing methotrexate may benefit in delaying the skin fibrosis. Sjogren's is mainly seen in females, may be primary idiopathic or may come with rheumatoid arthritis and SLE, secondary. Dry eye, dry mouth, dry vaginal mucosa, but the most common extraglandular problem they asked in the exam, it is arthritis. Now apart from arthritis, some patients can come with type 1 RTA, where they will come with hypokalemia and muscle cramps, and then you diagnose that they have RTA1. They may have some neuropathy, Raynaud's phenomena, cryoglobulinemia, lymphoma can occur. These are additional things that can occur, but the most common is arthralgia, and most classical thing they keep asking is RTA1. These two you should know, they are MCQs. The problem with the antibodies, they don't have sensitivity specificity, so you have to take the patient for labial biopsy, minor cellular gland. In the minor cellular gland, if you see lymphocytic infiltration, which are CD4, it is Sjogren. If you see CD8, it's HIV, so HIV is a differential diagnosis. Sjogren's patients, we always get a HIV tested to rule out, you have to rule out HIV because it's a differential diagnosis for Sjogren's. Treatment is mainly supportive care. Okay, this covers the rheumatology section. Moving to the pulmonology part. So if we keep taking break, I think it will take quite long. It will keep extending. Don't worry, pulmonology EI is quite small, so we'll finish it off. If you're looking at a patient with episodic airway obstruction, that's a feature of asthma. That's differentiating asthma from COPD. COPD is persistent generally. This is episodic. It will fluctuate. Patient has airway hyperresponsiveness because they will respond to beta-2 agonists. Unlike a COPD, dramatic improvement occurs on giving beta-2 agonist. And this patient has an eosinophilic inflammation in the airway. All these are primary pillars to prove the answer is asthma. How do you prove episodic? Ask the patient to get a peak flow meter. Between attacks, they will be normal. When the attack occurs, they will have worsening. So 20% variability should show. How do you prove airway hyperresponsiveness? Beta-2 agonist if you give, patient's FEV1 should improve by 12%. Or if the patient came normal, methacholine challenge test may cause bronchospasm. So this is going to be how you prove hyperresponsiveness. If the patient has eosinophilic inflammation, nitric oxide will come out. Remember, nitric oxide comes from eosinophils. These are the ways how we are able to prove that this asthma not a COPD. Okay, so you should have variability. You should be able to see after beta 2 agonist, patient shows an improvement of 12% in FE1, or methacholine challenge test can be used, and they should be eosinophilic inflammation. The way we classify asthma is intermittent, mild, persistent, moderate, and severe. And for intermittent, we use rule of 2. Less than 2 attacks per week, less than 2 attacks per month. Treatment is inhaled steroid and formoterol. In persistent, everyday patient should be on steroid, but whenever attack occurs, they should keep inhaled steroid formoterol in their pocket. In the moderate persistent, you have to give inhaled steroid plus LABA, and in severe, you're going to choose the drug depending on the additional, what patient's problem is. So this is the GINA guidelines on which this is based. The drug that we choose in step 5, this for step 5 you are seeing, step 5, if the patient has high IgE, give omalizumab. If patient has eosinophilia, use mepolizumab. If patient has steroid dependent asthma, dupilumab. And if there is non-eosinophilic asthma, then the answer is tezepelumab. So this is individualized treatment in step 5. Depending on the patient's problem, we'll choose the drug. In COPD, patient have emphysema or the patient can have bronchitis. So you will see a patient having this kind of an X-ray, which is barrel-shaped chest. Okay, normally the transverse diameter should be more. Here, AP diameter starts becoming increased. In this patient, the earlier classification used to be ABCD. The new classification is scrapped the ABCD. This ABCD thing is gone now. Now we're talking about ABE system. What is this ABE? The same thing. They merged C and D into E. They merged this into E. And they're telling the moment exacerbation occurs, you should call it E. And the new guideline, which is ABE system, okay, the new guideline is ABE system. What the ABE system is recommending is, for A, just use a bronchodilator. For category A, the treatment is just use any bronchodilator. For B, you have to use LABA-LAMA combination, long-acting beta-2 agonist and long-acting anti-muscarinic agent combination inhaler you are going to use. For E, you're going to use the same thing, plus you can consider adding inhaled steroid provided the eosinophil count is more than 300. If the eosinophil count is more than 300, add inhaled steroid. For category E, in addition, you can add roflumilast or azithromycin in the treatment. This daily antibiotic you are giving, or roflumilast. If you give daily azithromycin, the side effect you are worried about is deafness. If you're giving daily roflumilast in the patient, what you're worried about is significant weight loss. Okay, that's the side effect. So roflumilast or azithromycin is what is used in step E. So A, just use a bronchodilator. B, you have to use LABA-LAMA combination. E, you have to use LABA-LAMA plus inhaled steroid provided eosinophil is high. And in E, additionally, you can use roflumilast or azithro. In past smoker history, patient is a past smoker in the question, you have to go for azithro. Daily azithro will cause deafness. That's a problem. Okay, roflumilast is a phosphodiesterase 4 inhibitor. This is a phosphodiesterase 4 inhibitor. So these are the drugs that we use in the management of COPD. Okay, the old guideline of ABCD is scrapped now. Okay, no ABCD now, it is ABE. C and D are merged, and that E is exacerbation. Once exacerbation comes, it is E. And this is the new guideline for the management of COPD. Okay, this is how the COPD management now is. So all this is gone now, is gone, old one. This is a new one now. Okay. You can consider surgery in certain patients with COPD. This is called lung volume reduction surgery. Okay, this is referred to as lung volume reduction surgery. Now, lung volume reduction surgery you will only do if upper lobe is exclusively involved. Emphysema should involve only upper lobe, then you can do it. If you find upper lobe and lower lobe disease there, once lower lobe disease there, do not do lung volume reduction surgery. Long-term oxygen therapy has shown mortality benefit, but for that you should remember 55-88, these two numbers. The PaO2 should be below 55 and the saturation should be below 88%. Okay, only then long-term oxygen therapy has shown survival benefit. Okay. Otherwise, it doesn't show benefit. These numbers are important, 55-88. PaO2 below 55, saturation below 88, start the patient on oxygen. Oxygen which you're giving is low flow oxygen. Patient should take daily at home by oxygen concentrator, and he should take it for 16 hours out of 24 hours. Okay, out of 24 hours, minimum 16 hours if he takes, then only pulmonary hypertension will not come, and the survival will increase. In bronchiectasis, you get this picture called signet ring appearance. Okay, this basically the vessel, the airway is dilated. You can get cartilaginous syndrome, which is basically bronchiectasis, situs inversus, sinusitis, immotile sperms. You can get William Campbell syndrome, which is 4 to 6 order bronchi are having cartilage defect. Yellow nail syndrome will have lymphatic problem and lymphedema and yellow nails. Munier-Kuhn syndrome will be tracheobronchomegaly. Okay, all these are some of the syndromes that are responsible for causing bronchiectasis. In India, the most common cause of bronchiectasis, if they ask you, the answer is tuberculosis. Okay, post-TB bronchiectasis is very common in India. Clinical features are patient will have productive cough, sputum will be significant, hemoptysis, recurrent pneumonia infections can occur, and they may be associated with sinusitis, infertility depending on the additional problem. Like cartilaginous is there, then you get in sinusitis. Crepitations, bronchi and clubbing will be there in this condition. Treatment is get a sputum gram stain culture and start with antibiotics, but your main thing is you have to dry the airway. If you want to control the disease, you have to dry the airway. How can you dry? You try mucolytics. Then we try a lot of physiotherapy to get the secretions out of the airway, like physiotherapy, like postural drainage. Then we use some kind of ball valve technique where the patient blows, creates vibration. The vibration will shake the sputum and he can cough it out. We also use electrical vibrators that can oscillate the chest so the sputum can be coughed out. So all these are trying to be done to dry the airway. Once the airway is dry, the culture media it acts like the mucus for infection. That will be that the circle is broken. In interstitial lung disease, you should know idiopathic pulmonary fibrosis. If you look at NSIP, all connective tissue diseases come with NSIP except RA. RA comes with a UIP pattern. Okay, although RA we don't say IPF, but it's a UIP pattern. Histopathologically, it comes with a usual interstitial pneumonitis pattern. The difference is NSIP will respond to steroids, UIP don't give steroids. So in RA, in rheumatoid arthritis, when interstitial lung disease occurs, nobody gives steroids in the treatment because it is usual interstitial pneumonia. It will not respond to steroids. Then you have cryptogenic, RBILD and all that. Rest of them you don't have to know. Just the name you should know. Like RBILD and DIP is linked with smoking. They have asked that. Which interstitial disease occurs in smoking? It is RBILD and DIP. They are linked with smoking. And acute interstitial pneumonia is also called Haman-Ridge syndrome. It's very aggressive. Comes like ARDS. It presents like ARDS with very poor prognosis. Okay, looks like ARDS, very poor prognosis. So let's go through them. When you look at IPF, typically the patient is old patient, above 50. Progressive dyspnea and cough. Usually involves the lower lobe. And they have a special type of crepitation known as Velcro crepitation which you can auscultate. Inspiratory crepitation that sound like Velcro. Clubbing is a feature. Being a restrictive disease, the FE1 FEC ratio will be high but FEC will be low. The investigation of choice is HRCT. The MCQ will ask you, will you do lung biopsy? Answer is no. No lung biopsy, no, HRCT is enough. Usually ground glass appearance will not occur, indicating steroids will not work because ground glass means alveolitis. This patient, ground glass is very transient, may not be there most of the time, but you see lot of fibrosis. Because of the fibrosis, you get two things. One is traction bronchiectasis. The other is honeycombing pattern. Both these are lot of fibrosis. That's why you get honeycombing and traction bronchiectasis. Patho is UIP. Treatment is mainly supportive. Give oxygen, give pirfenidone or nintedanib, and ultimately patient is going to go for lung transplant. Both these drugs are intracellular tyrosine kinase inhibitors. So the classical pattern you are seeing are the lower lobe should be involved. The disease should be predominantly subpleural. The airway is pulled apart. Because the airway is pulled apart, you're getting traction bronchiectasis. The airway is getting pulled apart because of fibrous tissue. Honeycombing will occur usually in the subpleural area. Dependent area you can make out. Subpleural area you're getting honeycombing appearance. In patients with cryptogenic organizing pneumonia, it will come like a pneumonia. It's a subacute presentation. And the main clue for us is X-ray that will show consolidation. So when you see a consolidation, first thing you think is maybe it's a pneumonia, bacterial pneumonia, but there's no sputum. That will alert you this may not be the typical pneumonia. So in this patient, when you do contrast enhanced CT studies, you will get this picture called reverse halo sign. So reverse halo sign is a very classical feature of cryptogenic organizing pneumonia, and the treatment in this condition is actually steroids. It's a reversible condition. Patient will improve on steroids. Okay, this is for cryptogenic organizing pneumonia, reverse halo sign. They will improve on steroids. Allergic bronchopulmonary aspergillosis will have asthma, bronchiectasis, central bronchiectasis, skin reactivity to aspergillin, raised IgE and eosinophilia. These are all the features to tell you ABPA. So the main clue is going to be the bronchiectasis in the central area, central bronchiectasis, asthma, eosinophilia, raised IgE. Those are the features. Some kind of allergy is involved here. So what you want to do in the treatment is steroids and itraconazole. At this point, let me remind you once again that in patients with aspergillosis, even invasive aspergillosis, amphotericin is never your answer. Most invasive fungal infection amphotericin B, but for aspergillosis the answer is voriconazole. Remember, here it's not invasive aspergillosis, allergy, that's why you're using itraconazole. Okay, invasive aspergillosis answer is voriconazole, not amphotericin B. Hypersensitivity pneumonitis is type 3, type 4 hypersensitivity reaction. In acute it is type 3, in chronic it is type 4 hypersensitivity reaction. Clinical findings are within 4 to 6 hours of exposure to the offending agent, patient will get breathlessness, cough, crepitations, all this will start. On examination you can even see clubbing. X-ray will show ground glass appearance, which is the main hallmark for us, but the CT is the thing. CT will show something called mosaic pattern. Okay, this is shades of grey you will see, and this is ground glass only, but you will see shades of grey. It is known as mosaic pattern. Lung will show, like all interstitial disease, restrictive pattern, and the most important thing, this is not going to have a type 1, this is not a type 1 hypersensitivity, so you don't see eosinophilia. So what you want to do in the treatment is avoid the allergic source if you can, otherwise give steroids. Pleural effusion, if you look at the Light's criteria, the pleural fluid to serum, first look at the protein. Then you look at pleural fluid to serum, look at the LDH. Or just look at the pleural fluid LDH. So these are the three criteria for Light's criteria. Pleural fluid to serum, protein. Okay, it's 0.5, it is 0.6, it is more than 2/3. Okay, so let me repeat, pleural fluid to serum, protein more than 50%. Pleural fluid to serum LDH more than 60%. Pleural fluid more than 2/3 of the upper normal limit of LDH. Remember, in the third category, we don't have the serum, but we know what the normal serum should be. It should be more than 2/3 of the normal serum LDH. Light said any one of these positive is exudate. Any one, not 2, not 3, any one positive it is exudate. When look at ARDS, the PF ratio should be less than 300. PO2 FiO2 ratio less than 300. It must be bilateral, it must be acute, and it should not be due to cardiac cause. This is the main thing for us, that echo should not show LV dysfunction. If LV dysfunction is there, it is cardiac edema, not ARDS. ARDS, the attack should occur primarily at the level of the capillary. The capillary should be disrupted, causing exudate. It should not be back pressure from the heart causing pulmonary edema. The treatment is mainly ventilator support, and the tidal volume is kept between 4 to 8 ml per kg body weight. Patient should be on a positive and expiratory pressure. They generally need a high PEEP, but you can keep increasing PEEP until plateau pressure touches 30. Plateau pressure should be kept below 30 cm of water. As you increase PEEP, this will rise. Make sure this is kept below 30. Early neuromuscular blockade we used to do earlier. Now we're doing intermittent neuromuscular blockade. We start early, but we do intermittent, not continuous. We go for prone position ventilation and ECMO, and we reverse the inspiratory-expiratory ratio. All these are management in ventilator that you should know. And what you should not do is MCQs for us. Don't use surfactant, don't use steroids, don't use high frequency oscillatory ventilation, and don't use nitric oxide in the management of patients with ARDS. Main of these repeat question is surfactant. Don't use surfactant, it will not work. And don't use high frequency oscillatory ventilation. It will not work in patients with ARDS. Primary pulmonary hypertension, earlier we used to have 25 is the cutoff. Now mean pulmonary artery more than 20, new guideline is going for primary pulmonary hypertension. Progressive dyspnea, breathlessness, not cough, progressive breathlessness, what will occur in this young female. She will have some family history of mother, aunt dying of the same problem. So in this patient, pulmonary hypertension, lung is okay, only pulmonary vessels are undergoing change. So right ventricular hypertrophy, because of that you will say raised JVP, giant A wave, all these things will occur. This is all right heart failure that is occurring. In these patients, what you will see is pruning of vessel, means the pulmonary artery is dilated, but the vessels are constricted. Okay, the capillaries you can't see because the vessels are constricted. In a patient with primary pulmonary hypertension, we start with vasoreactivity test. If it's positive, give calcium channel blocker. If it's negative, then you start with oral combination like endothelin receptor blockers and phosphodiesterase inhibitors. So we generally use bosantin and tadalafil or sildenafil. This is the early combination we start with. Then if still the patient is not improving, then you can add prostacyclin analog. Only challenge is you have to give it IV. So this IV prostacyclin analog that you are going to add, still the patient has got a problem, then you can give triple therapy and ultimately take the lung transplantation for lung transplant. So they have asked in the exam, what's the first thing you want to do? Vasoreactivity test. Negative. Positive, you can use calcium channel blocker. Negative, you have to go for oral combination. Then you can add IV prostacyclin, and then all three you can use, and finally go for lung transplant. If you look at the treatment, the only new drug that is supposed to be showing lot of discussion is riociguat. It might be asked in the exam. It's working on nitric oxide pathway. Okay, so it is nothing but a soluble guanylate cyclase stimulator. It's a soluble guanylate cyclase stimulator, riociguat. It is supposed to help in relaxing the vessel and reducing the pulmonary hypertension. Okay, so you can use drug acting on endothelin pathway, prostacyclin pathway, nitric oxide pathway. We generally combine tadalafil with bosantin. If that doesn't work, then we use IV prostacyclin analog like eprostenol and treprostinil we can use. But now the new drug that is coming up is riociguat, is showing good benefit. Okay, they may ask this particular drug in the exam. Sarcoid is seen in females, hilar lymphadenopathy, erythema nodosum, arthritis. This is Lofgren syndrome. MCQ will tell you a patient coming with erythema nodosum and arthritis, ankle arthritis. What's the next investigation? The answer is chest X-ray. Patient does not have any pulmonary symptoms. But when the patient comes with erythema nodosum and fever and arthritis, you are supposed to get a chest X-ray done to check for hilar lymph node. And once you see hilar lymphadenopathy, then you say this is sarcoidosis. So AIMS asked a question. They said erythema nodosum, arthritis. What's your next investigation? Answer is chest X-ray. Okay, get the hilar lymph nodes. Do not use steroids at this stage. Supportive NSAID, the erythema nodosum will go away. Many of these conditions, the disease ablates at this point. If it progresses, then we'll use steroid. Right now, at this stage, steroid is not needed. Patients will have lung involvement, which will be progressive in sarcoid. They can have uveitis. This is known as Hereford syndrome. They can get organomegaly, lymphadenopathy, heart blocks can occur, cardiomyopathy, arrhythmias can occur, and in the skin, the special thing they ask is lupus pernio. Many people see the word lupus and think it's SLE. It is sarcoid problem. So the treatment is mainly steroid immunosuppressive, but look at the lung involvement. Only lymph node stage 1, lymph node plus interstitial disease 2, only parenchymal problem is 3, and fibrosis is there, that is stage 4. This is how we classify in sarcoid based on the X-ray. So patients can have sinusitis, patient can have renal stones, they can have hypercalcemia, because sarcoid, as I told you, is a granulomatous condition that increases the formation of vitamin D. Okay, it converts inactive vitamin D to active vitamin D. Neuropsychiatric complications can occur, seizures can occur. Granuloma converts inactive vitamin D to active vitamin D because they have 1-alpha hydroxylase activity. So treatment is basically steroids and immunosuppressive therapy. Okay, refractory cases you can use anti-TNF drugs. So this is all the things that you should know as far as sarcoid is concerned. Moving to hepatitis B, this is a DNA virus. The mode of transfer is vertical horizontal. Remember, whenever it comes from mother, it will become chronic because the baby's immune system doesn't recognize it, and that's why it will go into chronic. Whenever it comes horizontal, the immune in adult is very strong. It will pick it up, it will attack, the patient will get acute hepatitis B and they will recover. The recovery rate is 95%. Not only will they recover, after that they are protected as if they got vaccinated like that. They are protected, they cannot get the infection once again. They get like hepatitis A, they get the infection, they recover. Unfortunately, 5% of them, however, may go in for chronic. Okay, chronic hepatitis B, recurring inflammation of the liver will progress to cirrhosis. So horizontal mode, vertical 90% chance it will become chronic. In horizontal, only 5% chance it will become chronic. Serology is important. First marker to come out is surface antigen. First antibody to come out is IgM anti-HBsAg. Remember, these antibodies are not protective. What is protective for us? What is protective is antibody against surface antigen. The moment you see antibody against antigen, you can relax. The patient is getting cured. Okay, he's getting a control. He's recovering. Sometimes neither surface antigen you can see nor antibody against surface antigen. This window period, and the only marker you can see is IgM anti-HBCAG. Okay, there's still acute hepatitis B, but there's the only marker that is present. So if you see somebody having only antibody against surface antigen, this is vaccinated. The moment you see surface antigen, in your mind you should say this is virus is there inside. It's like, analogy is whenever you see smoke can't come without fire. Surface antigen can't come without the virus being inside the liver. So virus is definitely there in the body. That's why surface antigen came out. And once you say surface antigen, virus is there inside, you're now going to decide is it acute or chronic based on the antibody. It's IgM, it's acute. If you get with IgG, it's chronic. Remember, these two antibodies don't have protective role. The presence of them actually indicates infection, may be there along with surface antigen, right? If you get a patient having antibody against surface antigen and IgG, this patient has recovered. Okay, if you get antibody, remember surface antigen means virus is there inside. Once you get this antibody, you can relax. The patient is recovered. No more virus inside. But with IgG, if it's coming, he's recovered. If you get surface antigen with IgG, this is chronic hepatitis B. Every time the idea is same. Whenever you see surface antigen, expect the virus to be there in the body. With IgM, it's acute. With IgG, it's chronic. If the patient has no surface antigen, no antibody, only IgM is there, we just saw, this is core window period. This simply means patient has acute hepatitis B. Okay, this is acute hepatitis B. If a patient has no surface antigen, no antibody against surface antigen, last year INICT question, patient has IgG positive. Actually, window period you get only IgM. IgG positive actually indicates remote infection. This is because after the patient recovers, two antibodies are there in the blood. Many years later, antibody against surface antigen titer goes below detection. You can't see. Only one antibody you will see, that is IgG anti-HBCAG. That's why if you see only IgG anti-HBCAG is present, only this antibody is present, it means the patient has remote past infection. So be careful. If you get no surface antigen, no antibody, in IgM is core window period. But here the patient has recovered. And I was telling you, as long as you don't see surface antigen, you can relax. With surface antigen is not there, you don't have to worry. When surface antigen is there, virus is there inside. Okay, that's the basic idea. So in general, that means surface antigen, virus is there, IgG is chronic. Okay, E antigen only tells you replicability. It means it's highly infectious. That's all. Treatment is two things: interferon alpha and nucleoside analog. Tenofovir basically is what we use among the nucleoside analog. Tenofovir alafenamide. All the other drugs they don't ask. They ask in an exam, if you have got HIV and hepatitis B, what drug you want to use? Emtricitabine, tenofovir, lamivudine. Both work. These drugs work for both HIV and hepatitis B. Okay, you can use these. At that time, the MCQ had asked on emtricitabine. Works for HIV and hepatitis B both. If a patient has taken a vaccine, you have to take the titers. If the titers are more than 10, you are protected. Some people take vaccine, but their titer is less than 10. They are known as non-responders. In a non-responder, first you try a booster vaccine. If the patient does not get the titer, then you have to change the company and repeat the entire vaccine. If a patient is, this is in a patient who is coming to you, let's say you are all PGs. Before you join your PG, you got your titer checked. You found your titer was less than 10. At this point, you have not got any blood exposure. You just got your titer checked. It came to less than 10. You are going to try a booster first. If your antibody titer improved, good enough. If it did not improve, then you're going to report the entire vaccine by a different company. Correct? That's your management. But many times what happens is our PGs don't get the titer tested. They get needle stick injury. Patient has jaundice. Hepatitis B status of patient unknown, patient absconding. Your titer no less than 10, you got needle stick injury. You're worried now. What do you want to do now? This patient now, you're not protected. Remember, you got a titer less than 10. Then what do you want to do? Now, because the virus can reach the liver, first you stop that. You give hepatitis B immunoglobulin immediately. And then you repeat the vaccine by a different company. Entire course have to be repeated, full course by a different company you have to repeat. But immediate hepatitis B immunoglobulin, first is you want to protect the current exposure. You don't want the virus to reach the liver first. So this is the guideline. AIMS asked a question 2-3 years back, and they said a patient's antibody titer was some 34 or something. It was about 10. What do you want to do in this patient? They got needle stick exposure. Now what do you want to do? Nothing. nothing. They are protected. Don't have to worry about hepatitis B. Above 10, no need to worry. Below 10, your headache comes. So guideline is कि since hepatitis B spreadability is highest compared to HIV hepatitis C, that's why we recommend all students who are joining PG courses get the antibody titers tested before joining, because if you get anti-HBsAg titers less than 10, then you can do something about it. Before you get the blood exposure, you can do something about it. So get your antibody titers. Very simple test, not very expensive. Many times, you get your test done, you'll get 103, 104. Very good protection, nothing to worry at all. How long you want to treat? Remember, hepatitis B is not a curable condition. Chronic hepatitis B, acute, patient recovered. In chronic, the body will give up. It's a DNA virus. You can't hit only the virus without hitting your own DNA. So we are only controlling the virus. We cannot cure it. So E antigen, if it's positive, the first step is to stop it from replicating. So you keep giving the treatment until you convert to antibody against E antigen. That itself takes around 3 to 8 years. So you keep giving the treatment every day until you can convert E antigen to antibody against E antigen. After that, for one more you give treatment and you stop. Does it mean you're cured? No. It means the virus is so suppressed that until it raises its head once again, we don't have to worry. Okay, we keep following the patient. Again, if the virus increases, then you restart the treatment. If the patient is E antigen negative and the DNA copies are more than 2000, now you are looking at a special problem. This is known as precore mutant. This precore mutant hepatitis B virus is peculiar in the sense it will not be E antigen positive, even though DNA copies are more than 2000. Whenever DNA is more, E antigen should become positive. The fact that DNA is more E antigen negative is called precore mutant. Anybody having precore mutant is dangerous virus. This is basically high risk of cirrhosis and cancer. So nobody's got the guts to stop the treatment now. This patient will be on lifelong treatment. Okay, you cannot stop the drugs, lifelong treatment. Now this is for oral drug, remember. Pegylated interferon alpha you cannot give for more than 48 weeks because the patient cannot tolerate it after that. Doesn't mean the patient is cured. He can't tolerate after 48 weeks. So this is finite treatment. It's only for 48 weeks. Whereas nucleoside analog tenofovir depends on the scenario. E antigen positive until E antigen becomes negative, then 1 year. E antigen negative with high DNA, precore mutant established, lifelong treatment. If you look at hepatitis C, extrahepatic complications are more frequent in C than B. So lichen planus, porphyria, cryoglobulinemia. Anyway, the question they ask in the exam is what is not there? Psoriasis is not there. In this list, psoriasis is not there. So the repeat question is all are associated with hep C except. Answer is psoriasis. So non-Hodgkin's lymphoma, MPGN, diabetes, all these things are there linked with hepatitis C. Lot of diseases are linked. First 3-4 are very important for us. The ones that are light colored, they are possible. We don't know for sure whether they are really linked or not is question mark. Okay, we don't know for sure. The treatment for hepatitis C is major transformation. It's oral treatment, oral drug. Within 3 months we can declare the patient has cured. Very safe drug, very effective. You have to choose a combination from one of the categories. So you have all these drugs, isn't it? You have NS5A inhibitors, NS3A inhibitors and NS5B polymerase inhibitors. Generally, in all of these, the best drug is sofosbuvir. That has to be done better to give this for all patients. And you can choose sofosbuvir with one more of another class, but what we generally go for is sofosbuvir plus velpatasvir. Okay, this combination is supposed to be the best. Sofosbuvir and velpatasvir is the best. If a patient has got past partial exposure to these drugs, then you have to give soft well box treatment. Sofosbuvir, velpatasvir. So you're taking one from this class, one from this class, and one from this class. 3 drugs. If partial exposure to treatment has been done in the past, then you give all 3 drugs. If a patient has renal failure, sofosbuvir contraindicated. Then you have to go for elbasvir and grezopavir. You cannot use sofosbuvir if the patient has renal dysfunction. So patient is a renal failure. Don't use sofosbuvir. Elbasvir, grezopavir is the answer. If patient has alcoholic hepatitis, somebody is drinking from morning till night, comes with tender hepatomegaly. Hepatomegaly, this is not cirrhosis. Hepatomegaly with severe pain, abdomen and jaundice. Such a patient you will find AST ALT will be less than 400. Okay, it can be up to 400, never above that. And AST to ALT ratio usually will be more than 3:1. Okay, AST will be very high, ALT will be low, and none of these will cross above 400. So typically the MCQ will tell you AST is around say 320 and the ALT is around 62. Notice the AST ALT ratio is more than 3:1. When you see these patients, you want to calculate something called Madray's discriminant function. Formula for Madray's discriminant function is MCQ 4.6 into difference in PT plus bilirubin. If the sum of this is more than 32, if you calculate more than 32, this patient has to be started on steroids. Contraindication for steroid are if the patient has got pancreatitis and infection, can't use steroids. Such patients you go for pentoxifillin. So the contraindication for steroid is you got pancreatitis, you got infection, don't use steroid, go for pentoxifillin. Okay, 2 drugs you can use for alcoholic hepatitis, steroid, pentoxifillin. Main is steroid. The MELD score they have asked in the exam, and some of these mock platforms are giving total nonsense. They're telling everything is there in MELD score. Follow standard book like Harrison. It's only saying 3 things: bilirubin, INR, creat. MELD score only 3: bilirubin, INR, creat. Only recent modification they added sodium to this formula now. That's some modification, but definitely only these. Don't add everything possible. Albumin, everything they have added, that is nonsense. Bilirubin, INR, creat, only 3. You may add the sodium. This is a recent modification in MELD score. If patient has non-alcoholic fatty liver disease, they are prone for developing cirrhosis and all that. What do you want to do? Weight loss, and the new drug that is showing huge benefit is semaglutide. As you know, now semaglutide is approved just for weight loss per se, because it is showing very good weight control in patients. You can also use pioglitazone, saroglitazar, but semaglutide and weight loss is the main primary treatment for non-alcoholic fatty liver disease. Most of it is lifestyle changes basically. Hemochromatosis is a condition where you find iron overload. And in this patient, the problem is too much deposition of iron in the liver, LFT will get deranged. In the skin, melanin, iron together will create a slate grey color appearance. In the beta cells, iron can get deposited, diabetes can occur. These patients have a peculiar type of arthritis involving MCP, and in the metacarpopharyngeal joint, it will show osteoarthritic changes. So it will show osteosclerosis. But we know osteoarthritis does not involve MCP. So if you see osteoarthritic changes in MCP, the answer is hemochromatosis, pathognomonic finding of hemochromatosis. In the wrist, the cartilage can be calcified. This is called pseudo-gout. So this condition is linked with pseudo-gout. Okay, you get pseudo-gout over here. You get calcification of the cartilage in the wrist particularly, or the knee calcification may occur. Hypogonadism occurs, but the problem is not in the testis, in the pituitary, secondary hypogonadism. Cardiomyopathy can occur, thyroid disease and infections. So what you want to do in this patient, first workup is transferrin saturation and ferritin. In that also, if they ask you, the earliest workup is transferrin saturation. Then only you look at other markers. MRI is now coming up in a big way, because MRI can detect how much iron is there in the heart and the liver and can quantify. Earlier we used to do liver biopsy to do that. Now MRI is replaced liver biopsy in quantifying how much iron is there in the heart and the liver. Treatment is mainly phlebotomy, and iron chelators are additional option, but main treatment is phlebotomy. Okay, just remove the blood and the iron will start coming down. Wilson's disease is autosomal recessive, copper problem, metabolism problem, ATP7B gene defect. Problem is in excretion of copper in the bile duct. Young people develop the disease. Typically they come with hepatic or neuropsychiatric issues. Liver can come with acute fulminant hepatitis sometimes. The biggest clue that you have got a Wilson's disease is that the ALT, AST levels will be in thousands. It will be very, very high. Surprisingly, alkaline phosphatase may be normal. This peculiar scenario where AST, ALT alone is rising without alkaline phosphatase will tell you it is Wilson's. Okay, so it will be very high, but alkaline phosphatase is almost normal. That's a special feature of Wilson's. You can have basal ganglia problem, so you can have patient having a wing beating tremor. So this patient have a wing beating tremor. Okay, classically one side only. These patients can have dystonia. They can have drooling of saliva, Parkinson's-like features, and they can have neuropsychiatric. A lot of psychiatric problems are known to occur in this patient. If you get neuro problem, the Kayser-Fleischer ring is supposed to be almost more than 90%. 80% have written, but more than 90% will have Kayser-Fleischer ring if neuro problems are there. If neuro dysfunction is not there, only liver is affected, only 50% of them will have Kayser-Fleischer ring. So Kayser-Fleischer ring may not fall, the full ring you may not form. Most of the time what you see is upper pole and lower pole. So you can see it in the upper pole and lower pole. Generally you will be able to see only this area. That is got the Descemet membrane, you get the copper deposition. These patients can come with type 2 RTA, that is proximal tubular defect, fractures can occur, and hemolytic anemia is Coombs negative. Copper itself is toxic to the RBC. So get a slit lamp done. Ceruloplasmin is low. Because of this, be careful. Serum copper is low. So you know copper is high in the brain, high in the urine, everywhere high, but in the blood it's low. Why? Because ceruloplasmin is not there. However, free copper, if they ask you, be careful, it can be high. The main investigation is urine copper. It should be more than 100 microgram per day. If it's less than 100 microgram, give penicillamine challenge test and repeat the urine copper. If it's high, it is Wilson's. Treatment is penicillamine, triantine, tetrathiamidate, zinc. Of all these, zinc is the most useless one. Zinc is only for maintenance. It will not remove the current copper that is there in the body. In order to do that, the best drug still, unfortunately, is penicillamine. It's an old drug, but still is the main drug. Problem with penicillamine is it may transiently worsen neuro. If neuro dysfunction is there, you start tetrathiamidate first, then you add penicillamine. Otherwise, for everybody, penicillamine is the main drug. If a patient has SAG more than 1.1 or less than 1.1, then if the patient has SAG more than 1.1, you are dealing with portal hypertension. SAG less than 1.1, there is no portal hypertension. So basically it does not differentiate transferred exudate. It only differentiates is there portal hypertension or not. So the causes where portal hypertension are there are all these. Okay, cirrhosis, Budd-Chiari, heart failure, they all portal pressures are high. Because of the high hydrostatic pressure, ascites is forming. Here you see the portal hypertension is not there. Low albumin can cause ascites, or the permeability of the capillary is gone. That's how you can see albumin in the ascites. So both these conditions, the SAG will be less than 1.1. If you get SAG more than 1.1, ascitic protein less than 2.5, it is cirrhosis. More than 2.5 is heart failure and Chiari, Budd-Chiari syndrome. Again, SAG less than 1.1, low protein, nephrotic, high protein, malignancy. The concept here is that to get to spontaneous bacterial peritonitis, to get SBP, the ascitic protein should be very low. This explains why that patients, only when the albumin is very low in the ascitic fluid, opsonization will not occur, infection defense will become weak. So only cirrhosis and nephrotic syndrome develop spontaneous bacterial peritonitis. You don't see SBP in heart failure or Budd-Chiari or TB or malignancy. No, SBP is a feature of cirrhosis and nephrotic syndrome. In cirrhosis, it's E. coli. In nephrotic syndrome, it is pneumococci. H. pylori is gram-negative bacteria. Basically, what is the problem? H. pylori will come with peptic ulcer disease, may increase risk of gastric carcinoma, lymphoma. It may be associated with ITP, so this may be a potential MCQ for you. ITP association with with H. pylori. Everybody knows about lymphoma, gastric cancer and all that, but be careful, ITP is very important. Now, how we do the workup in patients is the patient above 50 or below 50? If H. pylori is above 50, our concern is cancer. We are not worried about H. pylori at that point, so we get an endoscopy done to rule out cancer. Along with rule out cancer, we are going to get the biopsy urease test, and if it is positive, you treat for H. pylori. Below 50 years, don't have to do endoscopy, don't have to be invasive, just check the antibodies first. If the antibodies are negative, rule out H. pylori. If the antibodies are positive, then you have to do either the urea breath test or you can do the stool antigen to confirm the virus is there, because the antibodies may be past problem. Once the antibodies are positive, you check the urea breath test or stool antigen, then if it is there, current infection is there in the body. So once you diagnose current infection, patient should be started on treatment. Okay, this is urea breath test. Once it's positive, start the patient on treatment. So I hope you understand, below 50 years, non-invasive testing, above 50 years, biopsy urease test. Post treatment, you're going to use either urea blood test or stool antigen to confirm whether the virus, the thing is eradicated or not. Now, as far as the treatment is concerned, one of the issues that we are having is the old drugs that we've been using called PCMA. Okay, this is basically this is from CMDT. So if you look at the current CMDT, this 2024 CMDT, okay, you can see Now the treatment regimens that we are looking at, earlier we used to use something called PCMA. What is this PCMA is? Proton pump inhibitor, clarithromycin, metronidazole, amoxicillin. That is not working now, resistance is there. So now the guidelines recommend you should go for bismuth based regimen. So what is this bismuth quadruple regimen? Is basically PPI, bismuth, tetracycline, metro. This is what is working now. Unfortunately, it is too toxic. The patients are not tolerating this so well, so we are now going for either rifabutin based regimen or vonoprazan based regimen. The hot and exciting thing is this vonoprazan based regimen, and this is where we are expecting the question. This vonoprazan. What is this vonoprazan? I'll just tell you. Okay, to summarize, in the treatment, go for bismuth quadruple regimen. What is bismuth quadruple regimen? Go for bismuth, tetracycline, metronidazole, and proton pump inhibitor. This is the bismuth quadruple regimen you should give for 2 weeks. This is the standard treatment now. Right now we are using in India. This is very difficult to tolerate for 2 weeks, that too. So the new thing coming up now is called PCAB. What is this PCAB is? This potassium competitive acid blocker. This is a new drug. It is superior to this, like PPI, but it's superior to PPI. Proton pump inhibitor is old now. Now we're talking about this drug called vonoprazan. This drug is in lot of charcha. Everybody, gastro people are crazy about this drug. They're talking about it. This is now the new drug instead of proton pump inhibitor. Supposed to be more effective and lesser side effects than pantoprazole, omeprazole and all that. Vonoprazan is the hot thing now. More powerful than PPI. Has a very good response in this condition. So we are now using this vonoprazan based regimen, and I was telling you that this vonoprazan based regimen, you can see is vonoprazan, amoxicillin, clarithromycin. This is now coming up. Now this is showing very good benefit. Now they are also trying the dual therapy vonoprazan, but now what we believe is this triple therapy is the better one. So this is, I think, the future. As of now in India, what we are using is bismuth regimen. Rifabutin is the alternative. Rifabutin also is there, but bismuth is the main regimen that we are using for most of our patients. So the old treatments we used to give, which were relatively safer, are not working now in most of our patients. They are not working, so you should be aware of that. Inflammatory bowel disease between ulcerative colitis and Crohn's. This continuous inflammation, this skip lesions. This will involve the rectum. This will spare the rectum, but it will involve the anal canal. Many students have this wrong idea. They think rectum and anal canal go together. No, be careful. Anal canal is Crohn's. Rectum is ulcerative colitis. So be careful of that. The skip lesion, it will skip across the rectum and involve the anal canal. Mainly in this condition, ileum is involved. Ileocecal junction disease. And mainly over here, rectum sigmoid is involved in ulcerative colitis. Bloody diarrhea is classical for ulcerative colitis. Don't see so much bloody diarrhea here. Rather, you will see mass in the abdomen and pain. Abdominal pain, mass. It's more classical for Crohn's disease. So in patients with Crohn's, fistulas, strictures, all these will occur. Simple idea is the outside serosa should be inflamed for the disease to spread to adjacent area. That's how fistulas and all can occur. Here the disease involving only the inside mucosa, so outside serosa not involved, so it will not cause stricture, fistulas, those things cannot occur. So these complications are exclusive to Crohn's. Now what do you want to do in the treatment? And extraintestinal manifestation you should know. What will respond to underlying bowel treatment? What is independent? What is classically independent is axial arthritis and PSC. They will not respond to underlying bowel. May respond plus or minus pyoderma and uveitis. Definitely will not respond axial arthritis and PSC. Surely will respond. You remove the bowel, this will go away. Okay, they will definitely respond. These two will not respond. They are MCQs for us. These two are plus or minus. Axial arthritis, primary sclerosing cholangitis will not respond. In the treatment, only know mild disease. Don't have to know the full. What's the first drug they are asking in the exam? Amino salicylates. What's the first drug in Crohn's? Budesonide. Many students have the wrong idea. They thought for Crohn's, ulcerative colitis, every time they'll tell amino salicylate. No, amino salicylate don't work for Crohn's. Be careful. 5-ASA doesn't work for Crohn's. So what do you need to do? Budesonide here, sulfasalazine. Here amino salicylates will work very nicely for ulcerative colitis. So the first drug is MCQ for us, and that's what they're asking. You may know the whole thing, but mainly what they're asking is mild disease. What do you want to do in the treatment? So this covers, I think, whatever best we could do in this small time. I think we've covered as much as we can. Acid-base disorder, nothing that concept-wise that I could tell. But just thing you should know, look at the pH, look at the carbon dioxide and bicarb, and then based on that you make a decision. So the idea is basically you look at the pH, carbon dioxide and bicarb. Let's say you are looking at 7.2, 26 and 12. Always start with the pH. If this is acidosis, write acidosis. Explain the acidosis by either carbon dioxide or bicarb. Carbon dioxide low can't be causing respiratory acidosis. It has to be metabolic acidosis, right? A low carbon dioxide causes alkalosis. So you have to label the acidosis. Let's say it is metabolic acidosis. Once you got metabolic acidosis, then you are going to find what the the compensation is. And compensation, you have various formulas. For metabolic acidosis, Winter's formula, carbon dioxide is 1.5 into bicarb plus 8 plus or minus 2. For metabolic alkalosis, the compensation formula is carbon dioxide is bicarb plus 15. Okay, this is for metabolic alkalosis. Okay, plus or minus 3 range. So this is compensation formula. So just go through the compensation formulas one, and you should be able to, ABG, don't think they ask so many questions. Once in a way they ask a question. But if you've seen my videos anywhere, or if you've gone through the lectures, you should not be able to have any problem in answering ABG questions. So I think we've tried our best to cover as much as possible. Whatever is the hot areas, whatever is the important zones, I have tried my best to cover. So finally, I can only tell you ki if you're not wasting time, then the next 30 years in your life you can get the reward for it. So I hope these kind of sessions are beneficial for you. Not much concept we can discuss in these kind of sessions, but whatever important I highlighted for you and I told you. So this is it from my side. Thank you so much, and thank you for all your messages and the kind words. So good luck and all the best.
Alright guys, so I hope this one shot program was very useful for you, है ना? So can I say that the entire subject was revised in a very quick amount of time? But as I told you earlier, this is not the end. Now what you have to do is you have to attempt the test. And how will you attempt the test? You have to download the eGurukul app if you have not done it. And in this eGurukul app, go to the test section. In the test section, go to the QR test. And in this QR test, you will see the test of this subject. Click on that test, gallery or camera. They will ask for a QR code, and here is the QR code. Scan this QR code or download it and put it into your gallery, whichever option that you want, and you are good to go. Please make sure that you are not finishing your day without attempting the test. I wish you all the best for the test, as well as happy reading, and I am sure that you will reach to the success in the exam ahead. Take care and God bless you all.